I'd like to introduce Dr. Anthony Lombardi. Dr. Lombardi is a 2002 graduate of New York Chiropractic College. He's a private consultant to athletes in professional circles, the NFL, the CFL, the NHL. He founded Hamilton Back Clinic. It's a very successful multidisciplinary clinic. I'm looking forward to getting there myself at some point. Over the past 21 years, he's presided over 100, perhaps even 150,000, I'd say, or more, patient visits. He was an instructor at the Contemporary Medical Acupuncture Program at McMaster University from 2004 to 2013. He's been teaching the EXSTORE system and has been mentoring physicians and specialists from all over the world. Since 2010, he's written several articles about motor point acupuncture in trade magazines and academic journals. Some of you, or most of you, know Dr. Lombardi, who has been training with him through online seminars and in-person live webinars and in-person live seminars. I know I can tell you from my experience, my practice tripled since I took on the EXSTORE program, and now I specialize in it myself. It's an exciting, it's a fantastic, life-changing, practice-altering practice or system, very simple and easy to use and very effective for most any musculoskeletal disorder. So with that, I'm honored to introduce Dr. Anthony Lombardi.
More excited, if you will, today, this weekend, because many of you, I recognize, many of you, this is the first time that you're seeing part of EXSTORE live, and this is going to be a great opportunity to, as this says, an introduction. But much more than that, over the next, let's say, 3 hours, what I really want everyone to take from this is clinical skills that no matter what technique you use, what therapy you apply, you will become 50% better, more proficient in your treatment of musculoskeletal care. And the reason for that is because the majority of the world that treats MSK, musculoskeletal problems, muscle and joint related pain, are unable to hit the mark simply because they treat every problem as if it's a mechanical problem. Every pain problem as a mechanical problem. Elbow pain comes in the door. They treat that elbow pain as if a mechanical injury or repetitive strain caused it. What the EXSTORE system does is twofold. One, it provides you the tools of a focused history so that you can understand the difference between a mechanical problem and what's called a chronic systemic problem. You're going to hear that over the course of the weekend, especially today. Chronic systemic means that patient may be presenting with an elbow pain, but they have with them pre-existing problems that change the way the body heals itself. And in fact, family physicians, MDs, surgeons, physical therapists, acupuncturists, chiropractors, massage therapists, the majority of them, first line of treatment, your elbow sore, they inject the elbow, they give you pain medications, they put needles in the elbow, they massage the elbow, they manipulate the elbow, etc., etc. And what happens? The patient does not respond, or in most cases gets worse. So you're going to learn from the lecture here today, because this is 3 parts. This morning is 3 parts. One is the live patient. I'm going to show you EXSTORE and a mechanical problem so you can see firsthand the changes that happen instantly, the changes you can apply to mechanical problems to get those changes. There's a lecture part where we break down what EXSTORE is all about. We talk about how to recognize chronic systemic. Because if you don't recognize chronic systemic, that's 50% of your problem. That's 50% of your problem. Treating a mechanical problem, treating a chronic systemic problem as a mechanical is the equivalent of driving the wrong way down a one-way street. You get farther and farther away from your goal, and all you do is you put yourself and the patient in more danger. And when I mean danger, I don't necessarily mean anything drastic, but if you're not getting the patient better, you're wasting time, you're wasting their resources for what? EXSTORE will build your practice. There's one part that I talk about how using EXSTORE won't just get you outstanding clinical results in a short time in mechanical problems. It won't just allow you to build the results you get into referrals. Patients will send you more patients, but it will give you the platform to produce revolving patient visits on a monthly basis through supportive care. We're going to talk about that. That's a huge platform, a springboard to get your practice in that where you have a lot of supportive care, patients that have had ongoing problems that need ongoing care. And there's indications for that. I list who should have supportive care. And guess what? The majority of the world needs it if they've had ongoing conditions. But EXSTORE gets you there because EXSTORE shows the patients outstanding clinical results that they've never seen before. And so I've been using it in my practice for the last 12, let's see, what year is it? Yeah, 12 years. And I still average 12 new patients a week. 12 new patients a week. So the average is about 4.1, 4.2 if you take manual therapists as a whole. That's really what you should be, that's what the average is. But it just happens. And it happens through referrals. So I'm excited to get started. The live patient. So our live patient today is going to be Moses. He has a problem. He's a mechanical presentation. I'm going to talk about this briefly. And then we're going to talk about mechanical and chronic systemic in more depth after the live patient presentation. So the game plan is to determine, is it a mechanical problem? And a mechanical problem is deficiency in movement, deficiency in strength, and really it's deficiency in both, movement and strength. So we find what isn't working and we correct it. A chronic systemic problem is a pre-existing problem. So it could be inflammatory arthritis, rheumatoid arthritis, lupus, scleroderma, psoriatic arthritis. There's an exhaustive list. Neuropathy, diabetic neuropathy, alcoholic neuropathy, any type of neuropathy in the peripheral or central nervous system. Fibromyalgia, depression, anxiety, chronic pain. All of that is a flag. And here's a kind of a hack. Where you find that, you can find within an instant the patient intake form. The patient intake form, you see that, and the more writing you see, the probably chronic systemic. And there's reasons for that. Without further ado, let's have Moses. So Moses will have a seat here. So essentially you want to find out when. When did it start? When does it hurt? Does it hurt during sleep? Where is it? Is it local? Does it travel? Can you describe the pain? Is it sharp? Is it achy? Is it burning? What happened? Is there a story behind it? What makes it better? What makes it worse? And what treatments have you tried? I'll go through these answers and highlight the flags, if you will, in the chronic systemic patients. Because that's the hardest part. EXSTORE, which you're going to see a glimpse of today, is simple. A mechanical problem is so easy to fix. So easy to fix. On the first visit, you probably get 80% improvement. On the first one, maybe 2 visits, if it's an ongoing problem and it's mechanical, maybe a second visit. But it's the first visit. And that's where the patients buy in. They say, oh, this is great, because they've never seen that before. Everyone else goes through kind of the traditional, and I mean traditional within their discipline, things that aren't working. Because if the things worked, they wouldn't have come to you. You wouldn't have been the 6th or 7th person on their list. So, first thing I have the patient do, I don't have the history here, but you're going to give us a brief history explanation. Moses, tell us what's going on.
Well, I have a case of chronic unrelenting aching sensation running from the base of my skull all the way down the left side of my back, mid-back, and it spreads out through the shoulder. Long history of martial arts training, bodybuilding, powerlifting, prior injuries, I had a separated shoulder over 20 years ago, and have been managing it ever since, and it just flares up from time to time. Specifically when I do incline pressing or overhead pressing movements, it gets pretty irritated and spreads all across the back part of the shoulder blade up into my skull.
Perfect. So, he said he had a trauma, a previous trauma, when we have a mechanical problem, and we're going to break this down in the lecture, we talk about motor inhibition. Motor inhibition means muscles that work suboptimally due to any type of noxious stimuli or undesirable effect. And there's 3 from the research. Pain is one. Trauma or repetitive trauma is another. And it doesn't matter how long ago the problem was, because if the body is adapting to that injury and we never get to reset that muscle that's inhibited, it's a constant cycle of adaptation. We talk about that. The last thing is changes in the joint, arthritic changes, tears in cartilage. As we age, typically we're going to get degenerative changes. All we need is mild osteoarthritis to set in. The very first research article came out in 1984 in Clinical Science that said mild osteoarthritic change of the knee will cause motor inhibition of, in that case, they studied the vastus medialis. And it's a muscle we're going to learn the motor point of today. So, to bring it in, Moses said he separated his shoulder 20 years ago. So that's probably the genesis of the problem, and he's been adapting ever since. I'm breaking this down for you just for the exercise of this so you really see it. But in real life, it happens more clinically efficient. Go ahead. Go ahead.
So, basically, not very much difficulty with using my the arm. No numbness, no tingling. Fully functional. On occasion, in certain planes or certain angles of movement, it may irritate, and I feel sudden. I wouldn't call it sharp, but a very strong throbbing sensation. Most of the time, it's an ache that just stems from the base of my skull down my upper back. Around, say, about a 3-4 level out of 10.
So you can see it's not very painful, but it affects his performance. And that's what you'll see a lot. Patients that come in where their performance is affected. And oftentimes they don't know that their performance is affected. They just know, well, it hurts once in a while. Maybe I'm getting old. I have this, that. I have old injuries. They don't realize how quickly the function, that adaptation can change. So what I'm going to do is, first thing I do, and we're going to touch upon this today because, again, this is an introduction, I'm just going to watch you walk, okay? That's the first thing I'm going to do. It's part of the assessment, and when we analyze gait, we essentially look at 3 things. We look at symmetry and asymmetry from side to side. We look at tempo, movement, flow. Is there a limp? And the last thing we look at is the movement of the upper and lower extremities. So I'm just going to have you walk. Just pretend this is a runway. He looks like a model anyway, right? Just slow it down just a little bit. Just speed it up just a little bit. So it's not bad. He's symmetric, but you can tell he's adaptive. It looks like it's a bit of an effort through his midsection. He's really not moving much. There is a lot of rotation. What you'll see sometimes in some people who are not well adaptive, he's very well adaptive. I mean, look at he's very good shape. He's exercises, so he will adapt. But someone who spends most of their time, let's say, on the couch watching Monday Night Football, and they do this over and over again, when they walk, you likely see things like one arm isn't moving, limps, things of that nature. Just one more time.
If I may add to this, as I walk, my left arm swing is it's an effort. Yeah. It's an effort. I feel it all along the upper back, shoulder blades. Very
perfect. All right. So what I'm going to do here is go through an abbreviated, what's called an EXSTORE scan. We're going to go through it in more specifics during the lecture. But essentially, what EXSTORE is finding the muscles that stabilize the girdles of the body, the scapular girdle in the upper extremity, the pelvic girdle in the lower extremity. And we look at the scapular girdle, and in the scapular girdle there's the scapula. How does the scapula move? I think someone mentioned it here. And the glenohumeral joint. So essentially, the shoulder itself goes into the shoulder socket, into the glenoid cavity of the scapula. How does that move? And both of them, how do they stabilize? What is their strength? So I'm going to do that right now. And simply from one side to the other. Because if we improve the movement of the scapula, we indirectly improve the movement of the glenohumeral joint, we improve the strength of both. And that changes the adaptability. You know what you're going to see here? And often I noted on Moses' gait, I mean, you could tell it was a little bit adaptive. He even said himself, he found his left arm was dragging a little bit. But for the most part, didn't look terrible. After treatment, it's like a rejuvenation. You start to see the real gait come through. The, what do they call that? Swagger. You start to see that because we've restored the function. All right, so I'm just going to go through an abbreviated version of the upper extremity scan. It's a little more in depth than this. I just want you to see the point and get excited about the results. We have people that are watching from all over the world right now through this thing called the internet. It's a new thing that's been around a while. So Lynn and I are going to be jostling for position here. All right, so simply we're going to start off with the testing of the deltoid, because the deltoid, it stabilizes the glenohumeral joint. And I'll start on the good side, so to speak. Hold that up. And remember, whenever you do any muscle testing of any kind, you never put your hand on the muscle that you're trying to test. So for example, if I'm testing his anterior deltoid, I push down, you push up. I wouldn't rest my other hand here because my other hand is stimulating it to contract. So if he were to be weak, he would test strong. Go ahead. And I test lateral. Go ahead. And now posterior, so I'm pushing this way. Go ahead. Very good. And now I'm going to test the scapulothoracic joint. Like I said, it's abbreviated. I'm going to look at the gross movement, glenohumeral joint, and the scapulothoracic joint. To test that, it's at 135 degrees of shoulder flexion. If this is 90, we add 45, it's 135. And I'm going to place my hand over the dorsal wrist. I push down, you push up. Go ahead. And you can even see, because I chose him because he looks like, a model from like Frank Netter anatomy books. You guys have heard of that, right? So, go ahead, push up. You could see his serratus anterior. Look at that. And look, this is beautiful. Look, you get external oblique here. Holy jeez.
Making me blush here.
Let's do the other side. You're fine. It's okay. So they have this thing called the internet. What happens is, hold this up. I push down, you push up. Go ahead. So this is his left side. Now remember, he's very well adaptive. But in the lateral, whenever you test lateral deltoid, that's if you're going to find an inhibition, it's going to be here. And it's a little bit weaker. And I'm going to push forward, you push back. Very good. So where you're going to see the majority of inhibitions in someone with a shoulder problem is testing the serratus anterior. That's going to be, and you can bet that is going to be inhibited. So 45 degrees, sorry if I'm blocking. I push down, you push up. Although you can still see the serratus anterior, it's suboptimal. The function is not functioning optimally. Go ahead, don't let me move you. Okay, let's try it again. And then what you'll see as well, if you really look at it, and we talk about this briefly in the lectures, talking about changes in the joint, changes in muscles that are opposite to the muscle you're testing. So the opposite to the serratus anterior is upper trapezius. So what the research tells us, when you have an inhibition of a muscle, serratus anterior, its opposite muscle, in this case upper trapezius, will form adhesions, will form trigger points. because the opposite muscle can't respond. For example, my bicep. When I contract my bicep, my tricep extends. But if I can't contract my bicep, just like you can't contract the serratus anterior, the antagonistic pair, in this case the trap, will form trigger points. And that's why it's important. Remember, trigger points are not, it's not the same as the motor point, and that's the consequence, not the cause of a problem. Trigger points are consequences due to maladaptation. Let's test one more time. So whenever I get this, this is where the practice building comes in. You have to explain to the patient, this is shut off. All right, let's do it again. Try to resist. And he should, like, this is not even scripted. This is for real. Look how strong he is. He should be able to resist, but he can't. So then I explain to the patient, I say, look, the scapula is the muscle that attaches to the scapula, that moves the scapula, called the serratus anterior, isn't functioning. So watch this. If I stabilize the scapula for you, watch what happens. And to stabilize it, I put it back to 135, and I put my finger on the outside part of the scapula, the lateral border of the scapula, very lightly. I'm not pressing. But what this does, it activates that muscle to contract more. So I push down, you push up, go ahead. And you can see the change, right? But if I take it away, go ahead, it's off. So at that point, the patient says, oh my goodness, wow, that's crazy. Because, you know, to a layperson, that is pretty, you know, impressive, I guess. But what's even more impressive is we're going to fix it, and it's going to have lasting changes. Lasting changes, I mean weeks and months, because what happens here, when I stimulate that muscle, stimulate the motor point, it improves the function. Now this is functioning closer to 100%. He goes back to the gym. He works out without maladapting. Guaranteed now, you're doing push-ups, you're doing bench press, whatever you're doing, you're recruiting other muscles. And because you're in good shape, you can get away with that. But he's going to go back to the gym, and his strength is going to be way up. And he's going to fire that muscle, contract the nerve that controls that muscle to a greater degree, and that muscle is going to grow. That's what's going to happen. So what I'm going to do now is I'm going to correct it. I'm going to do something very simple. I'm going to use one needle. I'm going to stimulate it. I'm going to do a little bit of muscle work. I'm going to have him walk again. And we're going to be doing motor points later this morning. 2 motor points we're going to learn. We're going to learn the vastus medialis, which is in the knee. And we're going to learn anterior deltoid, which is something that you will use all the time. Often, less is more. There'll be treatments, and as you see in the expanded course and the actual course, I wouldn't just do one needle and just send them on the patient's way. I want to show you the difference. I want to show you the point. I want you to be excited about the results. So I'm going to treat him right now. So lay on your right side. You let me know where you need me to be. So I use this tool. If you're not familiar, it's called a Pointer Plus. There's many different models. This is the first time you've seen it. Don't worry, we have plenty here, so you'll be able to practice. This, in my opinion, is the best model. I don't get any, what do they call, endorsements from Pointer Plus or anything. I don't even know where they're made, to be honest. But this is the Pointer Plus, the original. This is why there's many different ones, Pointer Plus, other models. They're just manufactured differently. They're okay if you have them. If you have it, don't go throw it in the bay or anything. You'll be fine. But I like this also because it's smaller, so I keep it in my pocket. Or if I wear the scrubs in the side pocket and I bring it from room to room. Although I have Pointer Pluses in all the rooms, so I don't really have to do that. And this activates the muscle that's inhibited. The muscle that's shut off, the serratus anterior, we activate that. Now, of course, the serratus anterior is an advanced point. When we teach it under supervision. When you practice it, it's under supervision of the instructor because of its proximity to the lung field. So don't, under any circumstances, practice it here in this room or anywhere unless you're trained. All right. So I'm going to get a needle. I tend to like to use bigger needles only because if I have more needle available, I can use it if I need to. If I'm using a 20 or 30 millimeter length and I can't get deep enough, I just wasted time. I wasted a minute. I wasted, if I waste a minute 15 times a day, I wasted 15 minutes. I might as well go home. I literally would go home. Like, there's no reason we should be wasting time on asking questions, on doing unnecessary assessments. If we're going to work, go to work. And that's the thing. And I think a lot of us, and they're not here because you guys are motivated enough to be here, right? But the world, they're just, I don't know what they're doing. And I'm disappointed in everybody. They really disappoint me. They do. Because you have such a gift, such a power, and you can help so many people, and you're wasting time. Anyway, that's just a sidebar. Longer needles, if you need it, it's there. So, what I'm going to do here is, this is being projected, good. I'm going to place your arm here. So the serratus anterior, of course, it attaches along the ribs, 2 to 9. Well, 1 to 9, but 2 to 9 is the part that's exposed. And I find it around the 4th. And I'm just going to go ahead and do it. I'm not going to get into the specifics of it. But what you will see as well, because the serratus anterior is at the core of the scapula, and what's around that is the latissimus dorsi. So you're going to get co-contraction of the lat, even the external oblique, the thoracolumbar fascia. And let's relax your arm here a little bit. And we're going to stimulate it. When we stimulate a motor point, we need to have your thumb on the plate. And you need to use your non-dominant hand. This is a bit of a different point where your non-dominant hand is intimately connected to the muscle itself, but you need to use overpressure. I'm going to stimulate this here. Just going to reinsert this one. It's so tight. Often what you'll find when you have a patient where the inhibition has been there a while, you'll find you just need to reposition. Let me see here. Just have you do that. Lift your arm up. I'm just going to have you put your arm right there. Just going to roll them forward a bit. It's so tight in here, a lot of restriction. There we go. There we go. Might be able to see it from the back even better. So you can see that depression happening. It's stimulated, look, all the way down to his pelvis. And because he's so tightly intertwined through his physique, through his conditioning, you will see you're getting all the way down. Here it goes. See that? Look, even his internal oblique is contracting. Just let your arm fall just a bit. Put it back up here. And all I have to do is stimulate it for a few seconds. Now that's his lat there. All right, that's enough. And then what I do is I do some soft tissue release. We're going to talk about soft tissue release this afternoon in the sports acupuncture. And you're going to learn very, very simple releases of the gluteal muscles, the gluteus medius, the anterior gluteus medius, the posterior gluteus medius, and how and why soft tissue work is so important. And just a modicum of soft tissue work can make a huge difference. So I'm just releasing that there. Because this breaks up the adhesions. The adhesion is what we talked about that gets formed from what we're going to learn more about neurogenic inflammation, the inflammation that gets released from the nerve in the area of that dysfunction, the maladaptation. All right, let's have you walk and then we'll retest. A really way to do is to check before and after. So a couple things I see here is upper body's moving better, but, and we're going to talk about this afternoon in the sports acupuncture, is we're going to talk about something, fascial lines. Fascial lines is understanding that although muscles exist on their own, they coincide with the muscles around them. So for example, the left serratus anterior, the line of tension pulls down to the right pelvis or the right sacroiliac joint. So based on his gait, and this is just coming from my observed eye, he's going to be inhibited on his right side because he was inhibited on his left side. And let's just test that. Does everyone follow? And we're going to see more of this afternoon. Even though I corrected the left side, he's likely still going to be inhibited. So I'm just going to test abduction. Have you lay on your back? Because there was a lot of adaptation and effort coming when he walks. Someone who's, exercises this much shouldn't have this much inhibition. So I'm just going to do a regular test of abduction on your left side. So I'm going to push in and you push out, okay? Go ahead. Push out. So stable. But on this side, I suspect he will be inhibited. Go ahead. Really try, really try. Yeah, shut up. But that's something that you recognize from applying EXSTORE, applying the principles. Well, we'll fix that this afternoon, okay? All right. Let's retest your serratus anterior. That's right. Sit up. I knew there was one more part. So then what I do in real life and practice, I say, okay, let's retest. And to show the patient, right? Because the patient's going to be like, no, that's, whatever they're thinking. It doesn't matter because they're going to be impressed. I push down, you push up. Go ahead. So strong. Go ahead, push up. Push up. And now I let him push up, and I'm not pushing down yet. All right, don't let me move you, okay? And now it's solid. It's
brand new.
Yeah, because now he's recruiting all these muscles. So when he goes into the gym or does push-ups, like sometimes, what I do sometimes at seminars is if the patient does push-ups, I'll have them say, okay, let's see how many push-ups you can do in a row. And they do like 18 or 20. And then after, they'd be able to do many more. Many more. All right, awesome. Thanks you. Let's give him a hand. So we just Yonat said, great question. Do we also treat the trigger points on the trap? Absolutely. Absolutely. That's part of the treatment plan. What we're going to be doing this afternoon, and it's going to be a technique that you would use there, but we're going to be incorporating it into the sports acupuncture, is a 2-needle technique or a closed circuit technique. So you would, definitely, yes.
At first, when you were stimulating, it was very jerky, and then it kind of got into like a smoother. So what was that? Was that
neuromodulation? Yes, regulation of the firing of that muscle. That muscle hadn't been fired in a while through the motor point, which we're going to be talking about the motor nerve, and that just activates it. Because when we activate the serratus anterior, or any motor point, but we activate it, the muscles, the tissues around it will co-contract. So it co-contracted the lat, right? And the lat pulls down. Yeah, that's perfect. Yes. No. Question was, after stimulating such a muscle like we just did, is that enough to stimulate that muscle? Or can you repeat the question so I can? So the question is, after how many treatments that will we recover full function? And usually it's after the first or second. But because there is adaptation, trigger points, adhesions forming, that's why it'll take a little bit longer. In general, I usually see patients a couple times a week for about 3 weeks and then reassess. Majority of the problems are corrected in that time. We'll talk more about that, but good questions. All right, so we talked about the game plan, we talked about the questions. Let's talk about the flags that you need to be aware of so you understand you're dealing with chronic systemic. And these are the signs. So pain is all the time. A mechanical presentation will be like, my back hurts. It hurts when I go from sitting to standing. It's episodic. Someone who's chronic systemic will say, when does it hurt? All the time. In the morning, in the night, when I get up, when I go to bed, 100, like 24 hours a day, all the time. Pain that's all the time is a flag. Unless it's acute, like I just fell down the stairs, so for the next day or so, I'm probably going to have knee pain a while. But we're talking all the time for like years. There's a problem there. There's a flag. And the flag, the chronic systemic flag is this. It's a dysregulation of the autonomic nervous system. Sympathetic nervous system and the parasympathetic nervous system. Parasympathetic controls sleep. It controls digestion. Sympathetic is fight or flight. Someone's chasing me with an axe. I'm either going to fight them or I'm going to run. But while that's happening, I'm not tired. I'm not like, hey, I'm going to take a nap right now. Someone's chasing me with an axe. No, I'm going to run, right? Sympathetic. All right? And I'm not saying, oh boy, I could really eat a hamburger right now. You're not doing that. So this is under constant stimulation of the sympathetic nervous system. That's what happens in a chronic systemic problem, no matter what the genesis of that problem is. So it's not a surprise that sleep is affected because sympathetic nervous system is constantly on, parasympathetic nervous system is not. It's like a swing. You can't swing forward and backward at the same time. We're either swinging forward or we're swinging back. We're either sympathetically activated or we're parasympathetically activated or balanced. No distinct onset or mechanism. Usually in a mechanical problem, I was playing soccer, I did a slide tackle, and I hurt my ankle. You've had the problem for a while. When did it start? I don't know. I'm not sure. I've always had it. What do you mean you've always had it? I've always, as long as I can remember. Chronic systemic, that's a flag. Pain is described as being everywhere. Where's the pain? Well, it hurts here, but the pain is everywhere. If the pain is everywhere, in every joint of your body, in every tissue of your body, it's chronic systemic. It's coming from up here. It's an amplification problem. And when I mean up here, I don't mean that the patient is, is struggling with mental illness and they're imagining the pain. They're definitely struggling with mental illness. Because if you're in pain all the time, you're going to be depressed, you're going to be anxious, you're going to be a bunch of things. And you're not imagining the pain. It's amplified. Nothing makes it better. Pain is constant. That's a flag. Often associated with, we talked about the psycho-emotional characteristics, of course. Anxiety, depression, often a trauma at some point in their life. If you want to call it post-traumatic, or it's a trauma response related to whatever incident or accident has occurred. In the joints, now we're talking more inflammatory arthritis. Anything that's bilateral. If a patient ever comes in and says, I have pain in both of my knees, I have pain at the bottom of both of my feet, I have tingling in both of my feet, that is not mechanical. That is chronic systemic 100%. So you have to think globally. And we talk about that in the expanded course. Today we're focusing more on mechanics. But the fact that you know this now, you're not going to make that mistake. You're going to be driving at least in the right direction when you pick up chronic systemic. Last one, pain is due to chronic systemic condition, like rheumatoid arthritis is responsible, or amplified by such conditions. Someone who legitimately falls down and hurts their knee and they're diabetic, they have diabetic neuropathy, or they have fibromyalgia, that's going to amplify that knee pain. And it's going to slow the response to healing. And that's so important because I tell the patient this. It says, look, you have other things going on. You have diabetes, you have this. Your body takes longer to heal. And when you tell them that, it's going to take longer. I can help you. I can help you. You'll improve. It's going to take longer. Once they know that, their expectations are managed because you know what happens? They go online on this thing called the internet, which is newer, but there's something called reviews, and they'll see all these great reviews, and they'll expect those reviews. But maybe those reviews were, not a condition even related to theirs. Manage their expectations and they'll stick with you. So this here, it's hard to see, but I'll walk you through it because it's not necessarily what's written. This is the intake form. So the intake form will tell you a lot. So for example, this says multiple neck issues. Let me get to this part here. It says all of the medications that they're on. They had ablations, prolotherapy, marijuana, baclofen, ibuprofen. And then over here, you see headaches, heart disease, asthma, lung disease, stenosis, lordosis, osteoarthritis. A bunch of stuff. The patient's like 35 years old. Chronic systemic, 100%. So right off the top, you know that. Before you even enter the room, you pull the file, you walk in, okay, this is what we're dealing with. So your questioning changes. Your questioning is not so much, look, because you're going to know, pain is all the time, I can't sleep, I've tried everything, blah, 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 they're depressed, they're anxious. You know that. So you know what the treatment's going to be. You know the path you have to go down. Here's another one. So this patient here, type 2 diabetes, heart disease, psoriasis, and then over here they had open heart surgery, leg stents, autoimmune vasculitis. That's not mechanical, and we know that. Before we enter the room, the clock's still at 0, and we know that already. Because once you open the door, the clock starts ticking, yes.
But can you also have a mechanical problem?
Absolutely not. You can have a mechanical, the question is, can you also have a mechanical problem? Not in the definition that we need to. Let's say they felt they...
You would never do like motor points.
Never. Yeah, good point. And I talk about that. Never do a motor point on someone who's chronic systemic because muscle spindles are sympathetically innervated, which means if you put a needle into a muscle of someone whose sympathetic nervous system is gone rogue, gone off script, it's good. That's why it makes it worse. That's why you don't get the results. But you can go into the skin, you can do distal points, you can do auricular points, you can do other techniques that we talk about, but never, never motor points. Good point. I'm glad you brought that up. I do talk about it. Let's look at another one. This one here is a pretty good. This patient wasn't too bad, but what's interesting about this patient is they talk about irritable bowel syndrome. They talk about mental disease, anxiety they wrote down. They had something else here. Some sort of toxicity in their blood. Mild Crohn's, irritable bowel. Crohn's, irritable bowel, ulcerative colitis. It's a digestive system. If there's a dysfunction in the digestive system, there's a dysfunction in the parasympathetic nervous system. And if there's a dysfunction there, the sympathetic nervous system has to be elevated. Chronic systemic. Question. Sometimes you get the CrossFit patients. I don't know if you've seen this before. The CrossFit patients that are chronic systemic, they have great adaptability. Right? So here's a CrossFit patient, and they come in, and the more writing you see, the more problems. I sprained my ankle. I'm not writing a life story because I have, I'm bad at soccer. I sprained my ankle, and I injured myself. But you go over here. This is important. Bowel disease, mental disease, endometriosis, anxiety, depression, thyroid disease, ulcers, chronic systemic, ulcers, digestive system, endometriosis, reproductive, thyroid, metabolism. But they're still training, and they're still, well, I don't know what they're doing, but they're, further depleting their body's ability to heal. You would think CrossFit, you would think, oh, mechanical for sure. No. You can't. And you have to explain that to them. So, what is EXSTORE? Let's get into more of EXSTORE. So, by now, thankfully we had Moses. He showed us that when we reveal motor inhibition, that's responsible for lack of movement or stability, and we do it among the scapular girdles, the pelvic, the body's girdles, the scapular girdle, skeletal girdles, scapular girdle, and the pelvic girdle. If I had to summarize it into three things, we assess. And that assessment after the history, when you get really good, takes a minute or two. Even 2 minutes is a long time. Guys, go in a room and just stand there for 2 minutes and tell me how long that is. That's an eternity. That's 120 seconds. 120 seconds. Man, that's a long time. Next, we neuromodulate. So we find what isn't working and we correct it. And the last part, and this is my favorite part, is we improve the function of the soft tissue. I call it renovate or restructure. And you do that through the application of manual. You do that, it could be through the application of gua sha or jade, but you need to change the topography and the nature of the fascia, of the soft tissue, in order to make lasting changes. If you don't do that, if you just assess and just do acupuncture, or assess and just do manipulation, or assess and just do exercise, your results are going to be so-so. And you're not going to impress anybody. Yes?
With chronic systemic, would you not even do EXSTORE because you're not going to do motor pulling?
Good question. Exactly. With chronic systemic, you don't do EXSTORE. Why? Because another flag for chronic systemic, just for fun, muscle test people, someone with chronic systemic, everything's inhibited. So let's say by some occurrence, that's a great point, Riz. Riz made a great point, because what happens is, if I read it, okay, it doesn't look like chronic systemic, I do the history, oh, this is definitely mechanical. I get in the room, I go through my scan, and everything is bilaterally inhibited. The deltoid, the external rotator, serratus, whoa, something's off here. That's a flag. And that tells me I'm not dealing with a mechanical problem. That's a very astute question. Then you would re-examine your question, say, tell me more. That doesn't happen a lot. And that doesn't happen a lot because we have the patient history. That's so important. I know all of us have a form of that, like I don't mean a little form, I guess it is a form. No pun intended, there's a form of, anyway. Use that to your advantage, because that allows you to streamline what's happening. Motor inhibition. So when we're dealing with motor inhibition, the nerve that controls the muscle is dysfunctional. It's not working at 100%. I say suboptimal. We talked about this. There's 3 causes of motor inhibition. That's noxious stimulus, undesirable stimulus, pain. So if I have ongoing pain, we'll say Moses, in his shoulder, right? And that can cause motor inhibition, and likely through the directional lines of tension. We saw his right gluteus, his abductors were shut off. That's one. Another one is trauma or repetitive trauma. So it doesn't have to be, he fell on his shoulder. It could be that he sits at a desk. If he, someone who has a desk job, always clicking a mouse, sitting in traffic, always doing a certain movement. That, over time, depletes the body's ability to adapt. And changes in the joint, which we talked about, which is typically arthritic change. And this is what happens. What happens, there's the muscle, that's the joint. You have the mechanoreceptors, the nociceptors. You have a noxious stimuli, and it goes down the sensory neuron into the dorsal column of the spinal cord. And when it gets spit out through the motor neuron, it decreases the function of that muscle. I like to call it garbage in equals garbage out. If you put in undesirable stimuli, you're going to get suboptimal performance. And what the acupuncture does, it restores the function of this loop. So it clears out all of that damaged information to maximize the output of the motor neuron. Here's a little diagram. So we have noxious stimuli causes motor inhibition, that causes muscle weakness, that causes something called neurogenic inflammation, which we're going to talk about shortly. And neurogenic inflammation is also a noxious stimulus, and that'll cause more motor inhibition. And this goes on and on and on and on. And no matter how well developed you are, eventually you're going to run out of the ability to adapt. Eventually you run out of credit. No more currency left for your body to adapt. This is fun. You're going to take this. It's going to help you. Because in EXSTORE we talk about clinical trends. Clinical trends. Whenever you have, and this is based on research. So if you have, back in the day we had an EXSTORE manual. We still have an EXSTORE manual. You can get it there on the website. But in the back there's tons of research, and even in the MotorPoint manual, which I'm going to refer to later, there's lots of citations and references. And the references tell us that whenever you have ankle pain or ankle injury, you will have an automatic inhibition of the abductors of the hip. TFL, gluteus medius. Same thing with the knee itself. With the hip, you'll have inhibitions of the oblique, so the body's ability to rotate the trunk and stabilize the low back, and the gluteus minimus, the deep abductor of the hip, inhibited. Low back pain, patient presents with low back pain, they're going to have inhibited obliques, gluteus medius, gluteus minimus. There's research dating back to 2012 where they actually, and they did this multiple times, patients with low back pain, they assessed using computerized sensors on contraction on certain muscles, testing how well, essentially EMGs on muscles in patients with low back pain. Every patient that had low back pain had an inhibition of the multifidus, the internal oblique, and the transverse abdominis. So whether they have really bad back pain or just a little bit of back pain, there's inhibition there, which means it needs to be corrected. In the upper extremity, any neck pain, you'll have an inhibition of the serratus anterior and a dysfunction of the bones that articulate with the scapula. For example, the clavicle. You're going to have a decrease in range of motion. And the same with any type of shoulder or upper extremity problem, wrist, elbow included. So this is why, even when we have a mechanical problem, let's say elbow pain, we don't, even if it's a mechanical problem, we don't go right to the elbow. We find what isn't working through our EXSTORE assessment and we correct it. And once we correct that, then we go locally to do soft tissue work there, some needling techniques, whatever we need to do to improve the function and break down the adhesions that form. That's why we go locally. We go local to break down adhesions. We go around it. We focus on the scapular girdle or the pelvic girdle in mechanical problems to fix the actual dysfunction, to improve the function of the body in that region. All right. So before we get into neurogenic inflammation and the demos, let's talk about why EXSTORE. Because this is where I always say that the EXSTORE course, you call it orthopedic, you call it musculoskeletal, it's business building. Okay, there's no greater thing you can do to build your business than get great results. I don't care. Look, I don't know anything about SEOs or stuff that they do on the internet, and I'm sure it works. But if you're not good at what you do, eventually you can't trigger, they might bite on the SEO or the click or whatever and come into your product. If, maybe I, wash windows or whatever. Maybe I'm a gardener and I'm a good price, and then they come out and I'm really bad at gardening. I'm bad at trimming the hedges. They're not going to use me. They're not going to refer patients. The best thing you can do is be outstanding. I just want you to do one thing, not 10 things. Just one thing. Be outstanding. That's it. Is that a lot to ask? No, it's not. It's not. You know why? Because you're here. You're here, right? I'm pretty sure there's more than 80 acupuncturists or people. There is, right? There's probably more, all of North America. More than 80? Definitely, right? Probably closer to 120, 125. I'm joking. Anyway, why EXSTORE? They're looking at me like, no, it's way more than that. All right. Results equal referral. So I started using EXSTORE about 13 years ago. In the last 11 years, like I said, I have averaged 12 new patients per week. This is what you can expect. Quick resolution of mechanical cases. And when I mean quick to what patients are used to, quick to what they've experienced to that point. And then you expect many patient referrals. But you're also going to learn how to build a loyal patient base through supportive care. Supportive care, maintenance care, it's important because we need to look out for the best interests of our patients. And what's going to happen is the patient's going to come in. Here's an example of supportive care. A new patient comes in. Patient follows your treatment recommendations. It's a mechanical problem. First of all, if it's chronic systemic, they're going to need treatment forever. Chronic systemic doesn't get fixed overnight. That's a whole other ball of wax. Patient follows your treatment recommendation. You find what isn't working. They come in twice a week for 2 or 3 weeks. You correct it. You give them the home exercises. And they do it, and they're feeling better. But they may qualify. When I mean qualified, there might be certain things about that patient or the history of that patient that they are going to be susceptible to re-injury. And so what happens is patient obtains the results that exceed their expectation, and when indicated, like I said, I see patients coming in every 4 to 6 weeks. Let's talk about numbers. 400 patients per month that come in on supportive care, that means 100 patient visits a week. That in itself, if you want, can be a practice. So in my practice, maintenance are probably 80, 85 a week are supportive care. Because I have a lot of chronic systemic, mechanical conditions that meet the criteria for supportive care. And the rest are either new patients or patients who are actively in pain or have re-injuries who are part of active care. And so I can see more. I see now 180 patients a week. But, you know, to see more, and I have seen more, I've seen about 210, but that's not sustainable. Then I would get to a point where I need to get other people helping me treat. That's a whole other ball of wax to keep the standard where you want it to be or where I want it. Again, the majority of the world in that realm disappoints me, right? And that's my problem. But I'm talking about you. You need to get there and understand that you can scale your practice like that, but it starts here. It's understanding simplicity. 400 patients a month, 100 patients a week. Yeah, that's a lot. So, this is good. I want you to take this, write it down. Indications. Well, who should be a candidate for supportive care? Is it everybody? No, it's not everybody. But it's the majority of people because of the way the world works. For example, if you're over 60 years old and you've had ongoing pain, it's in your best interest to get care, to keep you functional, to keep your quality of movement at a high level so you're happy with it. History of ongoing pain greater than 3 months. Patient comes to see me. They've had this ongoing back pain and they can't, they're having issues. If you've had the problem for 3 months, then you've maladapted for a very long time. And the older you are with time, and the population is getting older. Remember, baby boomers between the ages of 1946 and 1964, all right? That's the up-and-coming older adults. And they're not even that old. So you're talking 1946, patient 76, 1964, patient is 58. Is that right? 58. So they're 60, right? Arthritic change, adaptation. So if you have a seated job by itself or with a commute, you're coming for supportive care. Sitting increases disc pressure on the invertebral disc by 8 times. Not only that, but people who sit longer tend to be in worse shape, tend to be heavier, they're a disaster. All right, we know that. It's like there's no other way to describe moderate osteoarthritis. Oh, why did I change that? Moderate osteoarthritis, because you have motor inhibition, which means you have adaptation. Chronic systemic condition, fibromyalgia, diabetes, anything chronic systemic, you need care. And maybe it's not acupuncture, maybe it's chiropractic, maybe it's massage, and you need care. You do. You're not going to fix it yourself. You're not going to fix it by doing yoga online. No. You need manual work. I have nothing against yoga online. I'm just saying. It's part of the solution. High intensity athlete. So varsity high school, collegiate, pro athlete, they need supportive care for performance reasons to maximize their function. All right? It's like dealing with a race car. All right? How many race cars do you know that don't get tuned up? The losing cars. That's the ones. Marathoners, CrossFit, F45, whatever you want to call these things. It is brutal on the body. The training is brutal. They need supportive care. Or if they have a history of doing marathon or CrossFit. Dowager's hump. Now we're talking about physical. Dowager's hump, you see it in patients that see the cervical thoracic junction here, CT junction, and you'll see it's usually from bad posture, and it's like an accumulation of tissue. That's from neurogenic inflammation. That's from bad posture and adaptation. We're going to talk about that. That's just, it's from forward head care. It's bad posture. They need care. And then structurally, leg length discrepancy, one leg longer than the other, they're adapting the entire time. So there they need treatment. Maybe they need orthotics. They need something to restore the function. Scoliosis. And as we age, there's something called de novo scoliosis. So you cannot have scoliosis as a child, then you get older. Maybe you had back surgery, and it changes the structure of the spine, and gravity takes over, and it creates a scoliotic curve. That creates a leg length discrepancy. That creates scoliosis. You need supportive care. And of course, history of neck or back surgery, anything that changes the structure of your body. Making instant changes. That's what EXSTORE does. So let's talk about neurogenic inflammation. I'm getting excited because soon after this, we're going to practice motor points. Excited about that. So under normal circumstances, non-noxious circumstances, this is the sensory nerve. What gets dispensed from that are ions, water, proteins. We add in a noxious stimuli. We add in falling down the stairs. We add in sitting at a desk for 8 hours and commuting for another 2 hours. Every day, 5-6 days a week. That noxious stimuli produces neurogenic inflammation coming out of that sensory nerve. The neurogenic inflammation gets absorbed into the surrounding muscle, and that causes neural sensitivity and causes adhesion formation. Now, neurogenic inflammation, think of it as liquid glue, like when we were in elementary school. Remember that liquid glue came out, right? You guys know what I'm talking about, right? There's this thing called the internet. I'm just kidding. So people were looking at me like, what liquid glue? So that liquid glue, it's viscous almost like water, but it's very sticky. Neurogenic inflammation is in fact sticky. That's why they produce adhesions. This neurogenic inflammation sticks to the surrounding tissue. That tissue sticks to other tissues. That's a noxious stimuli, creates tight bands, knots, and trigger points. And that's a noxious stimulus, which causes motor inhibition. That's why manual work is so important. The jade work, the gua sha. We need to peel back the fascia, the tissue that's stuck together, because they're literally stuck together, because they're adhesions. That's why they call them adhesions. That's not a word I made up. That's what they call these changes in the topography of the tissue. How do we reverse adhesions? Well, non-noxious stimuli. Acupuncture, because that slows down the production of neurogenic inflammation. Electroacupuncture, even better. Manual treatment, because manual treatment provides mechanical and thermal stimuli, releases neurotransmitters such as GABA, dopamine, glutamate, and stops noxious stimuli in the brain. That's why acupuncture works. Acupuncture literally stops the pain experience. That's why distal points work, auricular points work. Even a point that's inside the tissue itself without going into the muscle in a patient that's chronic systemic will help decrease pain and help improve range of movement. I talked about this earlier, significance of a trigger point. It appears as a consequence of poor mechanics, not the cause of poor mechanics. Super important. And we do address the motor points. The trigger points. When we renovate the tissue, only after we've restored function of the dysfunctional muscle. It's a tight band. The trigger point can be a tight band, a knot, or trophic change within a muscle or fascia. It always appears in the antagonistic muscle when the agonist is inhibited. So with Moses, inhibited serratus anterior, knot, adhesion, trigger point in the upper trapezius. By the way, serratus anterior has two antagonistic pairs. It's not just upper trapezius, it's also rhomboid, because the serratus anterior protracts the scapula and the rhomboid retracts the scapula. It's kind of a side note. And is most clinically influential, what I'm talking about here, in a two-way antagonistic pair. So a two-way antagonistic pair would be bicep-tricep, serratus anterior upper trap, serratus anterior rhomboid. It means that the tricep, when the tricep contracts, its opposite is the bicep and vice versa. You have some muscles like the lateral deltoid, its antagonistic pair is the lat, but the lat's antagonistic pair is the middle trap, something like that. I forget exactly, but that's what's called a one-way antagonistic pair. Motor point neuromodulation. This is it. You have a mechanical problem. This is instant changes, and I'm excited about this, especially for those who this is new for. I'm actually excited. Even if it's not new, I'm still excited for you. My excitement is omnipresent right now. Introduction to motor point. So what is it? It's the neuromuscular junction. It's the point where the motor nerve attaches to the muscle, and it happens in the belly of the muscle. That's where motor points exist. We talked about the pointer plus. The pointer plus in this one here is preset at 10 hertz. That means 10 pulses a second. The newer ones or different ones, you can set that. They usually go between 1 and 16. 10 is optimal for motor point activation. And we stimulated 8 to 10 seconds 4 or 5 times like you saw in the demonstration. What's important, and we're going to go through this in this demonstration before we practice, is needle depth. The needle needs to be in the muscle. If it's too shallow, the patient will feel, I guess what you would call like the chi, right? And the chi is basically the needle that's in the fascia. Hasn't broken through, and when you stimulate it, it creates pinchiness or a sensory experience rather than a muscle contraction. And the non-dominant hand, what you do with your other hand is so important because we need to depress the tissue to get that needle as close as possible to the motor point where we can direct electron flow from the pointer plus. When do we use motor points? Well, to restore motor muscle activation for mechanical conditions only and to improve movement and stability of joints. So it'll improve range of motion, it'll improve strength in mechanical conditions only, not for chronic systemic pain, and we talked about why. We talked about the tips, depth, non-dominant hand, pressure of the non-dominant hand. You're really going to see this in the step-by-step form. And stimulation with the pointer. So grounding is your non-dominant hand. If you didn't ground the stimulation, the use of the pointer plus, the patient wouldn't feel, they might feel it, but we're not going to get an actual closing of the circuit. Again, in the demonstration, it'll all become very clear. The motor points we're going to be doing today: vastus medialis. Vastus medialis. It's right here. It's the muscle that has a fascial attachment to the medial meniscus. So the majority of knee osteoarthritis, always, there is a component of decrease in joint space on the medial side of the knee, which means changes in the joint cause inhibition. We know that. They did that back in 1984, clinical science. We're going to go through the vastus medialis. This is the manual I reference. If you don't have it already digitally, it's really good. But the thing is, the more you use it, the more you'll just know where to find these points. It's a great reference manual. It's small. I keep it in the clinic. Many do. They're out there as well. So it's the only hard copy. What does Josh say? The only hard copy manual in print. The only motor point manual in print right now in the world. That's true. You can look it up. And it has 92 motor points. And it breaks down, of course, the anatomy, the attachments, the action, the innervation, and then the GPS of the motor point itself. We're also going to talk about anterior deltoid, which helps with the stability and movement of the glenohumeral joint. And that's, again, that's from the manual. Practice. That means we're going to demonstrate vastus medialis and anterior deltoid. Okay, so I'm going to do some drawing. I can draw on you, right? This rubs off, I'm pretty sure. Just kidding, it does. So I'm going to delineate the patella because the patella is important I'm going to draw the patellar tendon because that's our landmark. So in the manual, I use landmarks and I use the unit of measure inches in order to determine where we go. Well, why inches? Because there is lots of literature on motor points that was printed, like the most recent one was, let's say, the 60s, the 70s, and they used the soon, okay? And so how I wrote this is I collected, and they're all referenced there, all of this resources, and found that I needed to use a unit that was constant, right? The soon is based on the patient, so it changes. And in fact, the soon has a accepted unit of measure already. And I have it in the manual. I forget. I think it's 1.3 inches, something like that. And there's a reference to when that happened and where that happened. And so what I did is I took all of the research. And for example, the research might have said this muscle is 5 soon from this point to that point. And I converted everything into inches. I divided it by 1.3. Turns out that the motor point, when I did that, ended up where? In the belly of the muscle. And the belly of the muscle is where the motor point is. That's why acupuncture, specifically motor point acupuncture, isn't point specific, it's region specific. So I don't have to be right on spleen 10. I can be in the belly of the muscle of vastus medialis and still get that contraction. All right. So he's got a nice vastus. Just contract for me, just for fun. Literally like an anatomy book. This is amazing. Look at that, eh? Great delineation of the vastus medialis. So what I do is I'm actually going to use, I was going to use a 40. I'm going to use a 75 just because you have more muscle there. So what I do is I find, you can relax now. I find, this is the GPS on how to find the motor point. Find the medial pole of the patella. And from here, I go superior 3 inches. And so back in the day, I would even have tape measures, and I still do, at live courses, just so you can get used to what an inch is. An inch, 2.5 centimeters if you're from a metric country. 1, 2, so 1, 2, 3, and then 1 medial. And you can eyeball it. Why? Because, again, it needs to be in the belly of the muscle, and it's region-specific, not point-specific. So here's kind of the thing that bothers me, okay? And I don't want you to make this mistake, all right? Before you do the motor point, make sure your needle is ready, okay, in your hand, all right? Because what people do is they will palpate, all right, 1, 2, 3, 1 over, all right, right there. Okay, great. Oh, my needle. So they get the needle, they pull it out, they get it like this, and they're like, oh, I have to repalpate. Like, oh, like this takes time, ladies and gentlemen, right? Oh, okay. Where's Huey? 1 needle at a time. You're fine. Oh, what are you doing? Be prepared. All right, this is an intro, so I'm not going to be mad, I promise. And even if I am, I'm not going to show it. I'm going to just internalize my disappointment. I'm kidding. It's going to be fun. People online are like, what is this guy? Yeah, yeah, you'll know. So be prepared, okay? Medial pole of the patella. 1, 2, 3 superior, 1 medial. And then what you do is, with the tube, I use the tube. You don't have to use the tube. It's just easier because it allows you to depress the tissue. Then with my non-dominant hand, I hold the tube and I flick it. Then what I do with my non-dominant hand, I switch my hand to depress the tissue. I don't touch the needle because, again, at this point, I still need to advance the needle. Okay, I can touch the needle when I stimulate it, obviously not when I insert it. And then I advance. And here, like I say in the manual, here would be approximately, ½ an inch or 1 to 2 centimeters. Turn, and I keep my hand down, okay? You want to keep your hand like this and use your fingertips. And then I just contract it. I thumb plate, press the button. You can see that. I'm just going to back off a bit. See that? There, I think that'll make it better. If you maybe come over top, there you go. See that? Maybe the focus is gonna, there it is. There it is. Yeah, see that moving? And even here, if you come around here, when you get a chance, to see the patella. Because it'll move the patella itself. Now the patella is intricately connected to the joint itself, the synovium. See that? So it's so important to use your non-dominant hand. You guys see that okay? I'm not going to look. I'm just going to assume it's working. And there you have it. So stimulate it for a few seconds. And then when you're in the groups, everyone will practice it. And then we'll go on to the next one. Yes, Riz?
How do we know the right amount of intensity to apply?
Good question. So the question is, how do we know the right amount of intensity? Like, for example, this here is at 3, we'll say, intensity dial. So, 1, if it's too high, you'll feel it in your thumb. Like, let's say you had it at 5 or 6. Also, here's the thing. Many factors influence the intensity. So I could stimulate it. If the needle's not deep enough, it's going to be painful. But it's not because of this, it's because it's not deep enough or I haven't used my non-dominant hand. So if the patient says, oh, this hurts or it's sore, then you have to reevaluate your depth or your non-dominant hand or the intensity of the dial. In mechanical conditions, usually never, very seldom will the patient start to say, oh, this is hurting, this is hurting. You'll see it a lot in chronic systemic. Anyway, that's what you'll see. So let's do the next one. Oh, this is great. We made a great time. Yes, that's because it's not deep enough. So either the needle's not deep enough or the question is, sometimes when the patient responds that it's very shocky or feels like electricity, that means the needle isn't deep enough in the fascia, which is the tissue that encases the muscle, the fascia, or our non-dominant hand isn't depressing the tissue enough. Just going to put this over here. So the next one is anterior deltoid. And you know what I'm going to do for this one? I think I'm going to have you lay on your back for it, just because it's a better demonstration. And how about I stand here so I'm not blocking anybody? Anterior deltoid. Anterior deltoid is very important in the stability of the glenohumeral joint. So what I'm going to do here is draw out the clavicle, outline it. And you have the acromion out here. The other thing we have as a landmark, because the acromion, that's one, the AC joint, that's one landmark. The other one is the anterior axillary fold, which is right here. So this one's nice because what we do here is we bisect it. So I'm going to draw out this muscle or outline it because you can see it again quite well. This is the anterior fibers of it. Sorry, just going to draw some striations just for effect. So, what's the next step? What's the next step? Get my needle ready. Exactly. Because if we don't get the needle ready, it's going to be an extreme disappointment. And I mean that sincerely. That I'd be very disappointed. But today, I'm going to be okay with that. I'm going to be okay. Really, I'll be okay with it. Listen, it's going to happen. All right? I'll get over it. AC joint or acromion. Anterior axillary fold, and we bisect it. All right? And right into the belly, advance the needle or insert the needle. So use your non-dominant hand as an exercise just to make sure the needle is stabilized. And then once you flick it, insert it, change hands to keep the pressure down. And use your non-dominant hand to depress the tissue around it. Remove it. And then advance. You got that jump. I don't know if you saw that. And then keep the pressure down. That's key. Don't, after you do it, don't take your hands off. Don't be like, okay, now what? Because then you have to get back in there again. And the more you handle the needle, the more you touch the patient, the more you press, the more chance you're creating noxious stimuli, which we don't want. We want to decrease noxious stimuli. So keep the compression down. Thumb on the plate. Compress. You see a very nice contraction. You can see elevation of the glenohumeral joint. See that? Well, maybe you want to come over top here. You good? Are you good? There, you see that. So you're getting flexion of the shoulder. See how his shoulder's flexing? I see that, right? There it is. Very good. And then remove. And then we go from there. So how about we do this? How about we take 6, 7 minutes, a break, we'll say. We'll call it a break, you know. I'm not a fan of breaks either, but it's okay. But drink of water, washroom, walk around, look outside, come back. And then we're going to practice. We're going to split up in groups of 3s over there, obviously where the tables are. And bring any equipment you have. We also have equipment. It's just the pointer pluses. Welcome, everybody. I hope you're enjoying the symposium so far from wherever you are. I want to take this few minutes to kind of do a tutorial for those watching virtually to go over, especially those where this is new, go over the basics of motor point insertion, stimulation. And even if this isn't new for you, it's always good to understand the basics, okay? Because sometimes in practice, we get away from the things that need to be addressed. Maybe we're not going deep enough. Maybe we're not spending enough time with our non-dominant hand. So I just want to take this time to go over those basics. And if this is new to you, this is just going to make you that much better. Because you could even be at home right now, and with, for example, the vastus medialis, you could do it into your own vastus medialis and stimulate it if you have the pointer plus. So let's go over the 4 main things. So I'm going to use the deltoid, okay? So number 1, as I said, make sure you have the needle ready, all right? And so some of the mistakes that I see, so I'm going to landmark, okay, top of the acromion and the anterior axillary fold, and I bisect it. So here's one of the mistakes I see. When I have the needle set here, one of the mistakes is even after insertion, the first thing that happens often is the non-dominant hand is not depressing the tissue. They'll just come off of it and do this. And the needle, what happens is if it's not in deep enough, it'll fall right over. But the next problem that happens very often is that when the needle is inserted, they insert it, as I call it, more classically, where it's more like advance a bit and they twist the needle, advance, twirl, advance, twirl. This, especially when it's in the skin, is causing more noxious stimulus than you need to be. We need to get through the fascia into the muscle. So please don't twirl and spin and advance. Just simply take it and advance it like this, as if you were doing this, if you could see my hand. Like you're just advancing the needle. So I'm going to take it and I'm going to go 1, 2, and it's in. Instantaneously, the noxious stimulus is dramatically decreased. No problem. My hand is still providing overpressure. This is enter the pointer plus, turn it on. Remember, if you're new at home, don't worry about the sensitivity dial. Just focus your attention on INT, intensity dial. And if it's a new battery, I keep it between just over 2, between 2 and 3. Make sure your thumb is on the grounding plate. And I hold it like this. Some people hold it differently. I like to hold it like this, almost like a wand. I've never really held a wand, all right? That's something that's found in magic, Halloween maybe. This is how you hold a pointer plus. And keep the pressure down, push the button, and we get that contraction. I'm gonna lower it a bit. You can see I'm gonna change position just so you can see more. That's probably coming up on camera, eh?
Not too much.
You can see the right here.
definitely have that.
Yeah. Let me see. I'm just going to move this over. There it is. Definitely see that.
Yeah.
Eh? Are you okay? And remember, another thing, and I'll mention this to the class, the head. Do you see the head of the Pointer Plus? That's the big ball. You want the big ball. There's a small ball that comes with it, no matter what model you have. You want the big ball so you can hook on, because you can't hook on with the small ball. So if I hook on, I can take the needle and I can pull it aside, or I can just touch the top of it. And it's very good for demonstration purposes, where I can get out of the way and really demonstrate it versus being right over it like this. So your non-dominant hand is super important. Now, once the needle is inserted all the way, you can touch the shaft with your non-dominant hand. You can do this. It's fine because the needle isn't being inserted anymore. And doing that will give you a deeper contraction. Can you see that now already? He's getting more adduction, more contraction there. So these are the little things. Make sure you have the big ball. Make sure you advance the needle without taking a lot of time, and use your non-dominant hand, okay? Have any questions at all? Email. Keep working hard. We'll see you on locals, or we'll see you in the live course if you're new to this in April in Albany. And then those of you who are veterans, you'll probably want to attend the clinical intensive in Hamilton, June 3rd and 4th. And that's very intensive. We treat real patients in a rapid fire form. You learn how to see multiple patients at the same time. You'll treat 3 patients at one time. Get 3 different rooms going. Those are for those who are very familiar with EXSTORE and veterans of it. Anyway, have fun wherever you are, and we'll talk soon. So as we filter in, I want to talk about, I always like to talk about some of the observations. Although we had a short time to practice, although it was only 2 motor points, although many of us were new at this, it was okay. It was okay. Like, there's lots of room for improvement. I'm just telling you this. I'm not going to tell you you were great because you weren't. And I didn't expect you to be great because this is new, right? So you did okay. Like, there's not much else to say about it. But I'll tell you what I liked. Just because I like something doesn't mean that it's good. It just means that I like it. And part of what I liked is that, in fact, I was impressed at how well you picked up the concept of tissue depth. That's usually one of the hardest things to pick up when you're learning motor point acupuncture, especially if you are not used to needling deeply, which more traditional concepts are more superficial. So, and that's why I chose those 2 points, vastus medialis, deltoid, that there aren't any structures that will put the patient in danger if you totally mess up, which you can't, because the couple things I do want to say that I need to see you, that I don't want to see, and don't ever do it when you're doing motor point acupuncture. When you're inserting the needle, what you want to do, let's say you select the point, you landmark, you insert the needle. At that point, once the needle is, let's say you've inserted the needle with the tube or manually, you need to advance the needle. Don't do things which you may have done before, twirl the needle, advance, twirl, advance, quarter turn, half turn. No, forget it. Insert the needle. 1, that's it, and it's in. Because the longer it takes for you to insert the needle, the more noxious stimuli you're going to stimulate, and there's no point. There's no point. You're wasting time, and you're exposing the patient to noxious stimuli. 2 of the things that are against you. In practice, you can't waste time, and you can't create noxious stimuli, especially when you shouldn't be doing it. All right? So really think in terms of, why am I here? Why are we in practice? Why are we in practice? to help the patient, to help as many people as possible, okay? And to maximize your ability to do so. I liked how you handled the pointer plus. I liked how you used the non-dominant hand, and you really did okay. You did, sure, I'll say you did well, but don't, listen guys, I'm telling you, it's always keep an even keel in practice. I always say, never get too happy when things are going really good, when you're clinically getting a lot of people better. Don't get too happy, and never get too down when things aren't going that well. Maybe you're saying, geez, I'm just, a lot of patients are coming in today. They're saying they're getting worse. Don't worry about it, all right? Just keep even keel, because every day is a new day, and every day you have the opportunity to improve. So that's what I got from the first practice session. And now we're going to practice again. This is what I'm excited about this. We're going to talk about sports. We're going to talk about sports acupuncture made simple. We're going to talk about some of the basics. And Dr. Lev and I, we go into in depth on a 4-day sports acupuncture course later this year in September in Phoenix, in Mesa, Arizona. And but today, I want you to really focus on the simple concepts that we talk about. And in practice, like practice when we practice, we're going to work on soft tissue, and we're going to learn a coupling needle technique or a two-needle technique. Very, very important to get your hands ready. Always apply soft tissue work. That's the difference between good results and really great results. We want to be really great. In fact, we want to be outstanding. That's what we want to be. We want to be outstanding. Try it one more time. We want to be outstanding. It's true. It's only one thing. I just want one thing from you. And the only reason I want it is because that's what I get from me. All right? And, often, and I don't have associates in my clinic anymore. Hopefully one day I will. And in part, the reason I don't is because I just don't see the fire. You have to have the fire. And what I ask of others, the only reason I ask it is because I ask it of myself. If you can't be outstanding, then you're just going to be in my way if we're working the same floor, right? Why do we have you here? That's the question I have. You need to bring value to whatever clinic you're at, whether it's yours, whether you're working somewhere else. You have to strive to be the best. And that really is the importance. And I bring that up because you guys are here, right? Out of how many other people that aren't here? It really comes down to that. Otherwise, you're wasting your time. What's the point? All right. I'm excited about this. So I brought, this is a thicker laser pointer because I'm going to need it for some things. I've added some transitions to PowerPoint. You'll be impressed. This is just, we had some questions. We always get questions about this, about locals. So, what's that?
They want to know who does your hair?
They want to, yeah, who does my hair? Well, that was when my hair was longer. My hair's a little shorter now. Locals Mentorship Community. So it's a place where you can earn CEUs, all right? It's a place where you can collaborate with other practitioners live online. So twice a month, we go on Zoom. There's a question and answer period. People bring in their own patients. It's subscription-based. And bring their own patients. We have question and answers twice a month. There's an additional webinar included, on a different topic, usually a very niche topic. And all of those webinars get put into the library. So there's a locals library. So this started in December, I forget now, December or November 2021. And so at the time I was producing 2 webinars a month. So in this library, there's about 70 different products. So when people subscribe, they don't only get the question and answer access, the 1 free webinar a month, the discount off live and webinars. There's a discount on that. There's a wall, we'll say, where people post questions, and within the same day I answer them. You know, I have this patient with trigeminal neuralgia or whatever the question is. So it always keeps us in the loop, and it's school away from school, keeping sharp and keeping interacting with people who are treating the same conditions and keeping us clinically sharp, as well as what's included is earning CEUs. I think you can earn up to 22 CEUs a year, and that's all included. And there was one more thing. There's the library. The library is huge, right? There's over 70 products, and it's all included. This is the live EXSTORE course. We got some questions on the break. It's April 14th, 15th, and 16th. This is more ideal for people who have never taken it live, who really want to learn the ins and outs of the course. It's a 3-day course, full day. And I mean full day, we're going from 8:30 to 5:30. I bring in about 7 live patients over the course of the weekend. We have open lab at lunch and after class. And it's tons of hands-on. What's included is motor points is in here. We cover 45 different motor points, different soft tissue techniques, different techniques on how to treat chronic systemic, manual work, and of course going through all of the assessment, the history, importance of blood work. It's in-depth and it's wall-to-wall work. You get a couple breaks in there, but there's always the opportunity to learn, because you came here to learn, you know, not to eat lunch or whatever else people do on breaks. But that's it. It's April 14th, 15th, and 16th in Albany, New York, the capital of New York State. It's true. All right, let's get started. Assessment and treatment of common golf injuries. We're going to go through some of that today. So first, muscle physiology revisited. Motor inhibition. We saw this not that long ago. Motor inhibition. Muscle that works suboptimally. 3 things cause it: pain, trauma, repetitive trauma, changes in the joint. Here is a diagram of spiraling dysfunction. Motor inhibition can cause noxious stimuli, or noxious stimulus can cause motor inhibition, which can cause neurogenic inflammation and so on and so forth. And it's bicyclical. It goes left, right. Noxious stimuli causes neurogenic inflammation. We have to stop that cycle. In a mechanical dysfunction, we can do that with motor points. We can do that with soft tissue work. We can do that with other needling techniques that we're going to learn and practice at the end of the lecture. Well, there's going to be a demo, and then there's going to be a lecture. We looked at this earlier on. The muscles, joints, there's nociception. There's mechanoreceptors. Garbage in equals garbage out. If there's noxious stimuli being sensed by the receptor, there's going to be decreased motor output by the motor nerve. So this is really important when we're talking about any sports injuries, muscle strains in particular. The difference between eccentric and concentric movement. Concentric movement, the muscle shortens, so like I'm making a muscle. Isometric contraction would be me pushing up against the wall or pushing up against an immovable object, creating a stalemate in the muscle. And eccentric contraction is when the muscle lengthens. So when I make a muscle, it's my tricep that's lengthening. So physiology of eccentric exercise, and the research suggests that muscle strains most frequently occur during eccentric phases of movement. And that's because the sarcomeres, which in the muscle are in charge of decelerating muscle movement, have the most tension on them during eccentric contraction. And these are the muscles which normally act as the antagonists, counteracting the movement performed by the agonist. And so eccentric movements increase muscle tension. So if eccentric movements increase muscle tension, then there's an increased chance of injury happening in eccentric movements. There's an example. Let's see what I have next. I'm not sure what that is. Oh, it must be the transition. It's like a fade.
Is this true for passive and active eccentric movement?
How do you mean by passive?
Let's say if you stretch your hamstring, you're stretching, that's passive eccentric move. So
You mean like walking? Like when I walk, this is eccentric in my, when I take a step, my quadricep contracts.
No, I'm talking about if you are, for example, just stretch your hamstring, sitting and stretch your hamstrings.
Yeah, that would still be, it would be considered active though.
Okay.
Yeah. Yeah, just a second there. Yeah, I went to change a slide. It just kind of went slowly.
That's the slide after the one.
Right. So eccentric movements, what's important about eccentric movements is to know that they provide more strain on the muscle than concentric movements. So back home, back in Toronto, there's something called the CN Tower. I don't know if you're familiar with this. It's a really big tower. You can't miss it. And every year they have, there's an elevator, but there's stairs. They have the walk up the CN Tower. So it's like people will sponsor you. They're collecting money for some sort of fundraiser, and they go up the CN Tower. So it's called climb up the CN Tower. But they never have climb down the CN Tower. Although you would think, oh, this is a lot faster, people wouldn't be able to walk like for the next 3 or 4 days after because there's tons of eccentric contraction. So that's one way I always remember it. Eccentric movements promote muscle strains more, and especially in sports, soccer, stop, start, things of that nature. You'll see a lot of that.
Wait, eccentric contraction would be going down the stairs?
For example, yeah. So on the hamstring. So if I'm going up the stairs, I'm going up, right? So I'm bending my knee. So I'm contracting the, yes. That's right. So reciprocal inhibition. We talked about this, but they're pairs of muscles that move in instant opposite direction. Agonist moves the muscle and antagonists do not oppose movement, like biceps and triceps. And the antagonist moves eccentrically. So reciprocal inhibition, when you have a muscle that's inhibited, the opposite muscle becomes contracted. Just the example of the upper trapezius and the serratus anterior. Serratus anterior is inhibited. Upper trapezius develops knots, adhesions, trigger points. See, that's what it was doing before. Two-way antagonistic pair are pairs of muscles that move in instant opposite directions. And we see a lot of this in golf. So the subscapularis and the external rotators, it's in the rotator cuff. Internal obliques and external obliques. So internal obliques on the right. So for example, if I'm turning to the right, the internal oblique is helping with the propulsion of the turn. But the antagonistic pair is the internal oblique on the left. The external oblique on the right propels my trunk. The external oblique on the left propels my trunk to the right. So this contracts, and the external oblique on the right works eccentrically. So a lot of people don't know this, the gluteus maximus and your psoas, your hip flexor, those are two-way antagonistic pairs. So there's different ways, and we learned this in the EXSTORE course, where we have someone presenting with, let's say, a gluteus maximus strain, inhibition of the gluteus maximus, and we'll learn ways to improve the function of the gluteus maximus without even touching the gluteus maximus. Serratus anterior and rhomboids and upper trap, we talked about that. They're kind of dual two-way. And hamstring and quadriceps. Golf swing muscle mechanics based on a right-handed swings. I might need you for this. So I'm going to have Moses come on up. And, but I still need that up there. Yeah, all right. So what we're going to do here is break down in very simplistic forms the backswing, the golf swing in terms of the mechanics of backswing and forward swing, but understanding that in each level of each moment in time in the movement, certain muscles are contracting and certain muscles are extending. So it's really important to see that. And by taking these tools, you can then apply it to anything. You can find a video of a golf swing, a tennis swing. We do one as well of a soccer player, where you can break down. And when you start looking at a movement and thinking in terms of concentric and eccentric movement, you start to understand mechanisms of injury more clearly. This is, of course, just an introductory lecture, but I want to give you the groundwork to really think clinically, to be able to look at something and process information. So what I want you to do is, let's have you, so this is based on a right-handed swing. So have you played golf before? Yeah. Okay, no, I'm just asking because I don't really play golf, but I want you to face that way. I think it might be easier.
This way.
Yeah, so you'll be like a right-handed swing. Quick fact about golf. I've golfed maybe like 3 times for real, in real life, like at a course where you go and it takes forever. But I can, so I don't own clubs, but when I go with friends, and whatever clubs they have, I use, because I can hit equally, I can hit the same from left and right. So I'm not breaking any records, but I keep the game moving. You look very unimpressed when I said that, but anyway. All right, let's it doesn't really matter. We're not really looking at technique. We're just looking at backswing, and I want to break things down. So let's go into the backswing and just hold it there. Perfect. So here, left subscapularis. So we're getting internal rotation of the left subscapularis, internal rotation of the arm. Serratus anterior is protracting. His scapula is protracting forward. Okay? When we talk about the right upper and middle trapezius, back here, if this is protracting, this is retracting. All right? So you can see what we're happening. You can just relax a second. All right, let's do it one more time. So he's rotating to his right, which means his left external oblique is contracting, and his right internal oblique is also contracting. That's how we're getting the rotation happening. All right, now let's go into a forward swing. All right? So what's happening now, the opposite is happening. His right subscapularis is internally rotating because his arm is internally rotating. This serratus anterior is protracting forward. The left, middle, and lower trapezius are going into retraction. And the right external oblique and the left internal oblique are contracting. And of course, you can bring it back. If the left internal oblique is contracting, the right external oblique is eccentrically moving. So when you break it down like that, you realize how simple it is. So when a patient comes in and says, my back hurts when I feel good, but I can't golf because I have pain when I swing. And then you can ask simple questions. Okay, what part of the swing does it happen? Does it happen in the backswing? And they might say, well, I'm not sure, right? Or they might say, oh, it happens, I can't, what usually happens is they can't recoil enough when they have back pain, so they go only half as much. So you understand, if you improve the backswing, the muscles which are responsible for the backswing, your likelihood of improving the overall swing dramatically increase. We're talking amateur players here, amateur type players. So it's important to see that. So this is what we talked about here. So in the backswing, so you can see he's, let's see, what is he doing here? He's doing a backswing in both areas. So the backswing is the right upper and middle trapezius is retracting, the left subscapularis and serratus anterior is protracting. Now, remember, if the left subscapularis and serratus anterior are protracting, the antagonistic pair to the serratus anterior is the upper trapezius. So that should be relaxed. But what happens is over time, you get inhibition. And this is why people who have inhibition, especially if they do something like a golf swing, where they're using, it's a compound movement, where they're using concentric and eccentric movement, their back, their shoulders are a disaster, an absolute mechanical disaster. But they continue to golf because, you know, they do it, you know. Here's the thing with golf, especially if you do it on an amateur level, pull off a golf swing every 15 minutes if I need to, or 12 minutes, or whatever the case may be, versus tennis. If you're injured, you can't continue because it's back and forth, back and forth. There is decreased rest between repetitions. In golf, huge, lots of time in between repetitions. So here as well, look at the right hamstring. The knee is bent, so that's contracted. The left erector spinae is in extension. That's the back. And I'm doing this just to show you to really, I want you to be able to look at something from now on and say, ah, this is happening, that's happening, and really try to analyze and try to see what's happening during each movement. It doesn't have to be golf, it could be walking. Watching people walk, that's the best place, you know, malls or any public place, anywhere where people are, watch people walk. It's really, really educational. And then this is the left external oblique because he's rotating right. The left external oblique is functioning. All right, let's look at the foreswing, the forward swing. So what happens as he comes through the ball here, that represents the ball, right pectoralis major is adducting, so that's contracted, right? This is his shoulder. Right serratus anterior is protracting. So the pectoralis major is contracting and the serratus anterior is protracting at the same time, which means on the other side, the rhomboids and middle traps are retracting because he's going through the swing. He's retracting. So the muscles that provide stability in the golf swing, here the right gluteus maximus in the hamstring, you can see the slight bend in the knee, and then the left adductors, which are muscles that we cover as well in EXSTORE as well, because that's part, it has an attachment to the pelvic girdle. And then as we get into the follow-through, early follow-through, late follow-through, we have here both pectoralis majors are contracting because, remember, if I'm like this, both my pecs are contracted. So if I'm coming through, they're both together. Subscapularis on the right, you see his right arm is internally rotated. Infraspinatus on the left, that's externally rotated. See his arm here. Gluteus medius on the right. The external obliques on the right. Vastus lateralis on the left. His left leg is extended. All right? And so as he comes through, you see how his knee is extended, and then the hamstring on the right, you see the knee being bent. So the best way to learn this is go to YouTube and watch one of these instructional golf videos, you know, golf for beginners, and they break down the golf swing, and you can analyze it, and you can see it. Ah, Scapular retraction, scapular protraction, and just watch it over and over again. These instructional videos are really, really helpful to clinicians to learn, especially if you're new at this. So late follow-through, there's exactly much of the same, just more of it. So golf and directional lines of tension are very interesting because, if you can come up here one more time. So let's have you just face that way, please. So what happens here is here's his right shoulder. You have tissue tension. Regardless of what the muscles are, there's tissue tension exerting from the top of his shoulder, comes across to the spine itself, and then carries on to the opposite hip. We saw that. Remember, your left serratus anterior was inhibited, and just by you were walking, I said, you know, I bet your right abductors are shut off. And it was. So what happens here in golf, this here is called the posterior torsional directional line.
Would you like to draw me?
Sure. Let's have you pop your shirt off. So, and I have diagrams of this up here, but I just want you to see what happens. You know what I'm going to draw it on you, and then you'll just go through the mock golf swing just so they can see the different things that are happening, okay? So, in general, we start from here, and it cuts across, cuts over around the center of gravity, which is around T10, like so. That's the posterior torsional line. One second. There's another one. Just raise your arm up. This one here. This one. Just turn for him. Just maybe move this out of the way. Oh. One second. That's fine. I'll get that later. This is called the lateral line. It goes from the roof of the axilla, mid-axillary line, all the way to the top of the iliac crest, where you can see it coincides with the posterior torsional line. And then, how we finish it off is have you turn. The anterior lateral line starts from up here and comes across and meets up with the posterior torsional line. So it's a sling. So during the golf swing, during the backswing, we're getting concentric contraction in certain muscles and eccentric contraction in the others. Let's have you turn. The lateral line and through here would intersect muscles such as the serratus anterior, the lat, parts of the external oblique, internal oblique, and then of course eventually all the way down the iliotibial tract, and then the peronei all the way down to the lateral malleolus of the ankle. So when we do, let's have you just go over here and we'll just go through that golf swing again. Actually, just hold it there. So we're getting directional tension anteriorly and, of course, posteriorly as well. So it's important because when we're treating athletes to improve their performance, because you're going to see athletes at high levels, collegiate levels, professional levels, where you're not treating them because they're injured, you're treating them to keep them tuned. And when we treat them, when we keep them tuned, and you'll see this in the sports course, we use techniques to help release the tension within the line, right? We're talking about the law of conservation of energy. He's like a spring right now. He's recoil. How can he generate the desired force by minimizing effort? It's all about the law of conservation of energy, especially when you're at a high level, no matter what the sport is. Okay, thank you. So here's the lateral line and anterior torsional line. So this is the lateral line. We just drew it. Goes right down through here. Serratus anterior. You see those slips? That's serratus anterior. External oblique, internal oblique. The anterior torsional line will come across here. We do that. I believe that's next. Anterior torsional line. So understand that those are where the forces are being generated. And that happens in the fascia, the covering over the muscle. But taking a step back and more primitive, when you're dealing with amateur or non-high level athletes, you're going to find tons of inhibitions. You're going to go through the EXSTORE scans, in this case upper and lower when golf, because golf uses the whole body. You want to assess both upper and lower and correct those inhibitions in mechanical problems. The posterior torsional vector, and this gentleman, so it looks like he's in the backswing, right infraspinatus, middle right trap is in retraction, lower left trapezius, and left external oblique, because the left external oblique is propelling his trunk to the right. So common areas of injury in golf. Low back, oh, we're in this one here first. Well, we saw this earlier, clinical trends. So remember, clinical trends. When we have a patient that comes in, ankle pain, we know we're going to have an inhibition of the TFL and the glute medius on the whole. Knee pain, the same thing. Hip pain, we're going to have the obliques and the gluteus minimus. Low back, we know we're going to have the obliques, transverse abdominis, the core musculature. Neck, shoulder, upper extremity, serratus anterior is going to be inhibited. And if serratus anterior is inhibited, which it usually always is when you have a neck problem, elbow, wrist, shoulder, you're going to have trophic changes, trigger points in the antagonistic pairs, the rhomboids, the trapezius. In golf, compressive load on the disc, the golf swing itself increases the compressive load on the disc by 8 times your body weight. Rowing is 7 times, to put it in perspective, because rowing you're seated. But the torsional compression on the joints of your low back are extreme in golf. It really is a dangerous sport with respect to low back pain, and I wonder why people do it, because it's boring. It's very slow. It takes a ton of time. Like, I don't see the point. But people like it. That's okay. You know, I don't have to golf, right? You golf. Maybe I'd go golfing with Moses, though, just because I like him. You know what I mean?
I'd be your caddy,
You would, well, I would probably need it. I'd carry yours. Amateurs. So here's the thing. And jogging is 3 times the compressive load. Again, jogging, terrible. Terrible on your joints. We know that. Amateurs use 80% more lateral bending and 50% more rotation than their professional counterparts. Obviously, they're not in as good a shape. They don't practice as often as professionals. And they're amateurs, so they're going to be flaws in their swing. They're going to get injured more often, which means they're going to be in your office. Greater arthritic changes at the facet joints, and research shows that there's more osteophytic formation, more arthritic change at L3, L4, which essentially is the middle of the lumbar spine. Shoulder injuries happen almost 20% of the time, 8 to 18%, due to overuse, subacromial impingement, which we're going to talk about now, and rotator cuff injury. Left shoulder adduction, all right? So in the backswing, it would be this shoulder, right? From repetition. And right shoulder external rotation in the backswing if you're hitting right. And then conversely, left shoulder external rotation in your follow through. The key is to assess these injuries. So subacromial space, this is the most important space in the shoulder for many reasons. So this is just a snippet. So this is the passageway for the supraspinatus muscle to come through. That's the clavicle. This is the scapula. It comes through here. And this is the coracoid process. This is the acromion, or the AC joint, and it comes in through here. This is a very high traffic area because there's a coracoclavicular ligament that goes from here to here. Then there's a coracoacromial ligament that goes from here to here. There is, attaching to the coracoid process, the coracobrachialis, which goes from here to here. There's the short head of the biceps that goes down through here. There's the pectoralis minor that goes from here. This is a very high traffic area. That's why one of the things that we show in the main course is how to release that area manually, because that traffic area gets gucked up with neurogenic inflammation, with repetition, and the release is quite, well, it's very specific, but very helpful. So what happens is, through many reasons, this gets jammed. It gets jammed because the subscapularis is inhibited, okay? And the subscapularis keeps the glenohumeral joint, keeps the head of the humerus in place. But if the subscapularis is inhibited, then this is going to ride upward. So if this rides upward, it jams the head of the humerus and closes the space between the subacromial space. They get pain when if it's on the left side, during adduction, and they can't go back all the way. But they adapt. They find different ways to do it, and they throw off everything else. Golf is so dangerous, and when I mean dangerous, I mean from an adhesion, soft tissue standpoint, that if you have a mechanical problem and you try to adapt, you have to throw literally everything else off because you're using your whole body to swing back and forth. And if you do that, let's say a game 80 to 100 times a game, and you do it 3 times a week, you're just destroying yourself. Yes?
So if you have a golfer and they have these inhibitions, low back pain, shoulder pain, do they need to stop the golf while you're treating them?
No, not at all. Not at all. In fact, I want them to continue to golf. What I do is you'll go in there, you'll correct everything that isn't working, and then I encourage them to go to the driving range or go to the simulator, and I tell them, look, go through and I want you to swing like you're teaching me or teaching someone else the proper golf mechanics. Get back to basics. And they'll go through, and because the thing is, they've been adapting so long, especially if you live in a climate down here when you golf a lot, that they think they're using good technique, but they're not. And they go back and they have to reprogram those muscles. So after a week, I would just have them go to the stimulator about 2 or 3 times over the course of a week to really get back into the groove of things. Good question. Good question. Subcoracoid space. So let's review. So the subacromial space is the space between the coracoid and the acromion. Subcoracoid space is underneath the coracoid process. And the ligaments that attach there are coracohumeral ligament. There's a ligament that goes from the humerus to the coracoid process. Now, this ligament is the ligament that's involved in what condition that you might see in someone with chronic systemic problem that might have diabetes in the shoulder? Frozen shoulder. It's coracohumeral ligament. That's the pain-generating structure. That's why they can't externally rotate. That was just an aside. Why did I say chronic systemic diabetes? 30% of people that have frozen shoulder have diabetes or some sort of chronic systemic problem. They just do. There's different thought process as to why it is. Just kind of an aside. And that's the space in between. Now, that itself will be more painful during the follow-through on my right side. So for example, if this is my backswing, when I'm coming through the ball, now I'm adducting my arm. This is where you'll see patients say, on my forward swing, I feel pain. When I come across, and I can't get follow-through. So that's why it's important to ask the patient, tell me, take me through, where do you feel the most pain? And sometimes they might not really know until they really think about it. They just know it hurts when I golf. Or they'll say, oh, it hurts when I hit the ball. But okay, so you hit the ball here, but is it after? Or is it literally right when you make contact with the ball? You know, or maybe they're hitting the ground. Right? And then they're going to feel pain reverberate like it happens, right? All right. Kicking a soccer ball. We're going to go through this. And what I like about kicking a soccer ball, again, soccer is a great game to play. More difficult to watch, I would say. You know, 90 minutes. You know, and I'm nothing against somebody. It's 90 minutes long, right? Like my friend, he's such a huge soccer fan. He said, oh, I watched some game. It ended in a 0-0 draw, and I watched it with him. We went to like a pub, and there were like 3 shots on goal the whole game, and he was like so into it. Oh, man, that was such a great game. And I couldn't understand it because it was like 90 minutes, man. Like you could cure people of insomnia if there's not stuff. That's why I love penalty kicks in soccer, because I think it balances the game perfectly, that for 90 minutes it's been, and now it's like, okay. Then I'm on the edge of my seat. I love watching penalty kicks, which is great because kicking a soccer ball is what we do during penalty kicks. Again, the two-way antagonistic pair. We've talked about this. We're getting a lot of that, which is really, really good. All right, so we break this down into 7 or 8 phases. So when we look at it, this is the approach to the ball. There's the ball. His left hip is flexed and his knee joint, left knee is bent. So we have left hip flexors, left hamstring. Obviously, he's leaning toward the target. His right knee is extended, which means his quadriceps are contracted. His hip is in slight extension. That would mean his gluteus maximus is contracted and his psoas muscle is eccentrically moving. Phase 2, and here is, look at this, the anterior torsional line, and this is another line that we didn't talk about today. I'm going to tell you now, so I guess technically we'll talk about it. We didn't break it down. Is the anterior line. The anterior line starts from the anterior portion of the top of the acetabulum all the way down into the top of the talus. We still have the left hip flexion, right hip extension, slight right internal oblique is contracting because as he lines up for the ball, he's rotating his pelvis to the right. And of course, if you're using your right internal oblique, you're using your left external oblique. They work together. And you have left scapular retraction. Right? When someone's kicking a soccer ball, we don't really look at the upper body, but there's left scapular retraction happening here. More right hip extension, which means more eccentric force on the psoas. Left hip flexion, this becomes his plant foot. The other important thing is there's dorsiflexion of his ankle right here. See how his foot is pointed into the air? Left scapular retraction, more so. More right hip extension. Now this is a plant foot, so the left leg becomes a point of stability. It's a huge point of stability. You see on wet surfaces, you see this. So this is many field goal kickers, almost all field goal kickers now in pro sports use what's called the soccer style approach to kicking a field goal. Back in the day, like 50s, 60s, they would do straight ahead. They would kick the ball with the toe or the front of the shoe. But they since evolved to soccer style. In fact, and the big reason too is because the rules changed in pro football where they were allowed to use different types of shoes, because the shoes kickers were allowed to use back in the day were very limited. And that's why for a period in the 70s and 80s, for those of you who follow football or historians, they were barefooted kickers. Who here remembers barefooted kickers in football? Right? Right? There you go. Right? There's a few. Tony Franklin, he was with the Patriots. There was a guy for the Chargers. He had this like Swedish last name. Anyway. But now, with the advent of better shoes and leniency in the rules, you'll see this in a lot of kickers. So you may get some football players coming in. So what happens is we go from extension of the right to flexion of the right. Now he's making his approach to the ball. The left hip becomes stabilized. Co-contractors are the hip flexors, adductors, and abductors, that entire hip. That's why it's so important to, when you go through the scan, part of the scan is the stabilizers of the hip. Right scapular retraction, we get some rotation in the trunk. More right hip flexion. So now it's essentially all of the same movements through the ball. And that's that in terms of, so we can see we start with, it's all about contraction, concentric and eccentric contraction. Any movement, any repetitive move, you can break this down with baseball pitchers. You can break this down with any type of racket sport. This is just a summary. This here, okay, there's a course I wanted to talk about, which has actually been quite popular as of late. So this is a course I have at my clinic in Hamilton, Ontario, Canada. It is called Intensive Clinical Training, and it is something that if you're a veteran practitioner, you want to be at to elevate your game. So what happens here, just 8 practitioners, 8, and I close the clinic for the weekend, and we start off by doing some review of the EXSTORE system, but things that I do a little differently than what I teach in order to streamline the approach. And we practice some different techniques, soft tissue techniques, needling techniques, and then the real people come. So it's constant flow of actual patients, real patients, my patients from the area. So throughout the whole weekend, each person will see probably 25 patients over the course of 2 days. And what happens, it starts off where you say, okay, you're going to see one patient, and this is our goal. You're going to do A, B, and C with the patient. Assessment, soft tissue work, and a team of patients will come in, and then we'll rotate. And then what happens is you start seeing 2 patients at once. 2 different rooms. So you learn how to leverage your time, how to use the acupuncture to buy you time so you can get this person started. Because if this person's on needles, there's no reason why you need to be standing next to them asking them how, you know, the series on Netflix is that they're watching or whatnot, right? You don't need to be there because the acupuncture is there. So you can get into the next room. And so I teach you to leverage your time, because in real life, that's how you maximize your performance, and that's how you maximize your clinical success. Maximize your time, maximize your income potential. So what happens is, by the end of the weekend, each person sees 3 patients at once. So you'll have 3 different rooms going at one time. You'll have plenty of time to document, and sometimes even a 4th patient in there. The last one we had in June, where, you know, the practitioners who are getting it or do it already to some extent in their clinic, you get 4 patients going at once. It's not hard. So it's very well timed, and you learn the skills to do this. So this is clinical training, and it's in Hamilton, and it's all weekend. So that's a great opportunity to get to the next level. So my favorite part of this one is going to be the soft tissue. We're going to do the soft tissue. Oh, sorry, was that a question? No? Okay. So, tissue regeneration with electroacupuncture. In fact, there is quite a bit of research that states that using electroacupuncture helps slow down muscle cell death and helps with the promotion, proliferation, and differentiation of new muscle cells to help repair and regenerate muscle fibers. But if you couple that with soft tissue manual work, gua sha, jade work, you further maximize and speed up the clinical results. And we're going to tell you why, because of how soft tissue heals. We're going to talk about the principles of soft tissue healing. Thermopolis et al. 2003 said it's well accepted that healing tissue should be loaded in a controlled manner to promote favorable remodeling. Loaded means jade work, gua sha, manual work, rehab exercises. Stages of soft tissue repair. This is super important. Let me take you through this. An injury happens between 0 and 72 hours, first 3 days, the classic inflammatory response, accumulation of inflammatory cells, swelling. That's why, in general, we put what? We put ice. You know, I sprayed mine, we put ice on it for the first 24 hours up to 72 hours. Then 72 hours to 6 weeks, which is called the repair phase. Repair phase, between 72 hours and 6 weeks, collagen is being formed at the area of injury, but in an erratic or non-controlled, non-organized manner. It just keeps getting put onto that area. After repair phase is remodeling phase. Remodeling phase is when the collagen starts to form to the stresses that you put into it. So if you don't get proper treatment, okay, and you have the repair phase and you just start limping around, that collagen solidifies into what becomes scar tissue during the remodeling phase because you're constantly adapting. What's interesting about the collagen remodeling phase is that the remodeling phase starts at 3 weeks and the repair phase goes to 6 weeks. So there's a crossover of repair phase and remodeling phase happening at the same time. This is why getting treatment sooner the better when you have an injury, specifically an ankle injury, any type of rotator cuff injury, shoulder problem, is key, because otherwise you're going to get the solidification of collagen forming irregularly, which is going to contribute to motor inhibition and long-standing dysfunction, because it doesn't, nowhere does it say that if this happens, you need to have pain. What happens is you sprain the ankle, oh, I hurt myself, but then, oh, the pain went away. And so the pain's gone, but all that scar tissue has remained, which means you're not dorsiflexing, You're not contracting your quadricep. You're putting more pressure on your knee. It's affecting your hip extension. It's affecting, you have more flexion in your low back. And if you take 10,000 steps a day or 5,000 steps a day and you multiply that by a month, that's 150,000 steps, and then so on and so forth. And then eventually you run out of credit. You run out of the ability to adapt, and you have pain. This is why supportive care is so important in anyone who's had these injuries, or runners, or things of that nature. So today we're going to learn the supine abductor release. I'm going to show you how to release this area just by working in this high traffic area here. What's key is the number of passes. This will dramatically increase range of motion of the hip and your SLR, your straight leg raise. 30 to 35 passes. You have to do minimum that. 30 to 35 passes. So a pass means, we'll show you what a pass means. But in essence, what I go for when I do the soft tissue work is about 50 passes a minute. So just, a little over 1 a second. So just think, if you start using soft tissue, people say, well, I don't have time to use soft tissue or this. First of all, you have time. But let's just say you didn't have time. All you need is 2.5 minutes. You can get 120 passes in there. That would make a huge difference in your tissue healing. So I'm going to just describe this, and then I'm going to demonstrate the soft tissue and the needling, and then we're going to practice it. So a coupling needle technique. So we're going to show this one here, the 2-needle technique. So when would we use the 2-needle technique? So we had some really good questions in the morning where we talk about the trophic changes. So let's say we find muscles that are inhibited. We go through the scan, we correct it. The antagonistic pair. So let's say in Moses, he had a lot of tightness up in his trap. We would use this technique on the trap to break down that tissue, to get that moving better. We have a patient that, say, has neck pain, pain when they turn, and you go through the scan and we find there's an inhibition of the serratus anterior. Well, we correct the serratus anterior, but the patient still has, well, they'll still get more range of movement, but we go in there with 2-needle technique, we deactivate those trophic changes, those tight bands. They're going to have more range of motion. So that's where you would use this technique. It's done after inhibition is removed. It's done to decrease neurogenic inflammation, because it's the neurogenic inflammation that contributes to those adhesions that we're actually trying to get rid of. And it helps with the restructure of the soft tissue through soft tissue release. I want to show you what I use. Right down here, these are the specs. So we run it at 2 to 4 hertz and 10 to 12 minutes. Now, when we practice it, I just want you to set it up. You don't have to do 10 to 12 minutes, just a minute or two, just so you can appreciate the contraction you're getting and the patient can feel it. So as a patient yourselves, you can appreciate what's happening. There's different models. I brought 2. I just want to explain it because it's important. I think I just put it in my bag here, sorry. So there's different models. This one here I really like. This is called the EXSTORE 2, but there's an EXSTORE 3. I think it's one of the prizes being raffled off. And this, essentially what we do, we put in 2 needles just to simplify it. And then we clip the needles, red and black. And we run low frequency milliamperage stimulation, 2 to 4 hertz, and we want to see the contraction. We don't have to see the contraction. What I tell the patient is, as long as it's non-painful, all right, that's the key. We don't want to create noxious stimuli. So we can turn it up and we can get substantial contraction, but we don't want to have the patient to have any pain with it. It's called EXSTORE 2. This one here is called There's different ones. There's the ETO, ES130. This is the ES130. And there's another one, something 1107 that I had. So these are extremely durable. I have some that I bought in 2002 that still work. These ones here, the numbers are worn off. Just from like, this one probably had, I don't know, 30,000 uses, something like that. Pretty crazy. Well, we changed the battery, obviously. But. So these are going to be used as well today. All right, I'm going to demonstrate that. Perfect. So just move this over here. Give me a hand. Oh, yeah? Okay, couple of things. One, we know he has an inhibition. That was his right side. So we're going to retest that. We're going to test your range of motion on that right side, like a simple straight leg raise. So we can see the difference just by adding soft tissue. And it's your, maybe we'll use this as the head.
Okay. It's
All right, so I just want to test the range of movement of his, the straight leg raise. So you can see here, pretty flexible. Nothing really to report here. On the right side, so I bring this up, you can tell there's a lot of guck happening in the front, in the hip. And the straight leg raise, let's see what it's like here. It's not bad. It stops around here. Not bad. Let's retest again, just for, go ahead. I push in, you push out, push out. And go ahead, push out, push out. So that's definitely shut off. So what I'm going to do here is the soft tissue release. Just bend your knee. So how we do this, now this would normally be done after, you want to do soft tissue after needling. But you can do it before. It's fine. I'm just going to show it before, just because I want you to practice both today. So the first thing you want to find here is the ASIS, the anterior superior iliac spine, and that's the bone at the top of the pelvis. It's okay, you can stay there. Right there. And maybe I should just mark it. Thanks. Perfect. That's right here. And the second one I want to find is the head, the greater trochanter of the hip. Pretty straightforward. What you want to do after that is you want to bisect those 2 points. So you want your contact to be in between those 2 points, anywhere in this area. So in terms of contact, you can use your thumb, or you can use your fingertips. Depends how big your hand is or your position. And what happens is, so this is my right hand on top of the knee. And you notice my stance. That's important. I don't want to be bent over. I want to take a nice wide stance, or whatever is comfortable for me. And what I do from here is I create tension. Soft tissue is all about tension. So if you use your thumb, you'll lock in like this. But what happens is I'm not pressing in the tissue, I'm pressing down and across. It's like I'm dragging the tissue. And what I do is I lock on, and then what I do is my other hand brings his leg across his body, like this. Like this. And as it's going across the body, there's more tension being transferred into the thumb. So if you look really closely at my body, watch this. I'm not doing this. My body is moving, okay? I'm not just doing this. As as there's adduction of the hip, I'm leaning into it. And that's providing the overpressure right into the thumb. Or if I use my finger pads, I like my finger pads because I can get about, let's say, 3 finger pads on there. So it's a wider contact. And then I can bring it across like this. So then I get into a rhythm. It's almost like a movement. You see what I'm doing? I'm just leaning in, leaning in. And so I'm going to do about, let's say, 35 passes, something like this. I can bring this up a little bit more. Flexing the knee more if you can will get you a little bit more grip on the knee. And it'll make it more comfortable for the patient. And what I do with my hand, I change the position. As long as there's only one rule in soft tissue, that's create tension. As long as you're creating tension, then you're doing it correctly. What you don't want to do is do a lot of compression because you're just staying in one spot. And between here and here, you want to move in different locations because that'll release, by doing this, you're releasing all of this fascia. All of this fascia. So the main reason in the research, if you look up determinants for straight leg raise, right? So this is a straight leg raise, leg straight, bringing it up. For outside of neural tension, outside of like a disc injury, what contributes to the decrease in the angle of the straight leg raise? And everyone would think, oh, it's hamstring, right? It's not hamstring. It's the iliotibial tract. The tighter the IT band is, the iliotibial tract, the more the straight leg raise is affected. So by releasing this, you can make dramatic changes. You okay? All right, just going to do that. Now we're going to, just to demonstrate 2 things, range of motion and even strength. It'll help the strength a little bit for sure. But see this? Your flexibility is dramatic, right? And what did we do? Not a lot, right? Right? So this might be considerably stronger, but go ahead, push out. Go ahead, push out. It's definitely stronger, but you could tell it's still an effort for him. It's definitely stronger, but the needling is really going to help. So let's do that. Let's have you lay on your left side. I'm just going to grab 2 needles. Yes?
Does it make a difference if you go perpendicular?
The question was, does it matter if you go perpendicular to the muscle fibers for soft tissue, right? In fact, because there I was perpendicular, I was angular, I think it makes a difference as long as you're perpendicular, but still your line of tension has an element of, that your line of drive has an element of tension to it, for sure. Because when we release the psoas and things of that nature, we have to have compression, but it's compression with an element of tension. All right, so like a shearing, yes, yes. So here, for this one here, what's great about the coupling needling technique or the 2-needle technique is that it's not like motor points where there's a specific instructions or directions. Here, you needle into the tight band. So you feel your palpation assessment, where the area is tender, where the area is tight. There is where you insert, in this case, a 2-needle technique. So I'm going to insert it right here. Because remember, we're needling the consequence, not the cause. So I'm only using a 40 here. I'm not even sure if these are 40s. Not sure. But anyway, oh, this moved on me a bit. All right, going to advance it. And this one here into the hip, I'm going to put this. Did you say that's a 40? Or?
Yeah, that's like 40.
Yeah, you're right. And so I have one needle and I put the other one directly beside it as if I want the tips of the needle to contact each other. Then I clip the alligator clips. Now, ideally, does it matter where you put them? No, but it's ideal to put the black distal to the red because it's driving the current toward the brain, toward this central nervous system. So this here, what I really like about this model is although it has one less lead, like the Ito has 3 leads, this has 2. This has specific frequencies, 2, 10, 20, 30, all the way up to 100, which is key for different techniques when using high frequency in different types of injuries we learn in the main course. But here I'm going to keep this at 2. And this one here is the second channel. So I go to this one here and I turn it on. Also, what I like about this is that they feel the contraction earlier on. And I think because they're thicker wires that we get a more succinct contraction. Does that make sense? Yeah. All right, so I'm going to start the stimulation. And we're probably going to see a contraction here. Say that again? Where do I put the intent? What number? Usually around this one, around 2. Oh, it's moving already, and this is at 2. So let me turn it around. Yeah, I'm going to increase it just for effect. There it is. So we want movement, but we want non-painful stimulation. And it's pretty, how would you say it is in terms of comfort?
It is comfortable. But I can feel the impulse running through into the joint, creating external rotation on the leg. It's good. It's ideal.
Is the foot moving? Maybe a little bit. So I know this is just intro, but I want to give you a little bit more. So this is how it would work. For example, this is just a simple 2-needle technique. If it was an actual treatment, I probably would be doing other things. But regardless, at this point, I keep the patient on this for about 10 or 12 minutes. So usually I do this before the soft tissue, okay? But I'll have them on, and then I leave the room, and I give them a bell. So if they have an issue, they can ring the bell, or issue being that maybe the needle fell out, they have to use the washroom, they have pain, something like that. It happens rarely. And then I can go into the next room and get that patient started. And once I get that patient started, or 2 patients started sometimes, usually, then I come back here, deneedle him, and while the other patients are on needles, I'm doing the soft tissue work here, finishing up. All right, he's going to come back next week. And then I go in to the next room, and by then I have another patient waiting for me in another room. And then I usually have 4 patients, 4 rooms at once. The more rooms you have, the more opportunity you have to really get this going and not waste time. That's the key, because this allows us to really maximize our ability and our time. Whether whether you're TCM, massage therapist, chiropractor, physical therapist, and so you might do manipulation. See, with massage therapy, what I find too is I have them in my in the clinic. You can only, outside of the acupuncture, when you're doing massage therapy, you have to be there. So you can't be massaging 2 people at once. The great thing about what acupuncturists do, or chiropractor, or anyone who practices acupuncture, is that you don't have to be there to apply the treatment. This is applying the treatment. So that's a gift. That's a beautiful gift because it's the best stimulation of the peripheral nervous system and the central nervous system, and you don't have to be there. I can't think of a better thing.
It seems like you always say you do Easton for about 12 to 15 minutes. Is there like a secret sauce for that, or why not 30?
Question is, usually I have them on for 10 to 15 minutes, and the question is more better? In some cases, yes, but in general, with something like this, 30 would not be good because it would put you behind. Because timing, yeah, because you need the room. Yeah, that is more than enough. And doing the soft tissue. When I mean the room, like you need the space for another person to be in there. There's one webinar. Go ahead. Yes.
Does this soft tissue manipulation will be safe for someone who has hip replacement?
Yes. The question is, would the soft tissue manipulation be helpful with someone with hip replacement? Yes, for sure. Yeah. Very well. Yeah. Question. So the question is, sometimes what happens when you leave the room, the contraction might speed up or become more profound, or conversely, less. Typically what happens is, remember, the patient might move or shift and change the way the needle is in the muscle and the contraction of the muscle. I just try to keep them as comfortable as possible. I usually put a pillow between their knee. Keep them occupied. Like I encourage them if they want to look at their phone or whatnot, fine, you know what I mean? Because that tends to keep them distracted and not thinking about it. And sometimes what happens if the needle's not deep enough, it even happens to me, the contraction causes the needle to become less deep. So if, for example, it's clipped at an angle where it's pulling the needle, and sometimes the needle falls out, I've had that happen. Not often, but...
Just try to start them off.
Yeah. For sure. Yes?
Would this treatment also be applicable for somebody with chronic systemic issues?
No.
Even this you don't do?
Yeah, because this is in the muscle. The question was chronic systemic conditions. Would you do this treatment? Not in the muscle. You could do it into the skin, and there's different techniques for that, but not into the muscle. Yeah, the comment was sometimes they give the patient, the EDO to the patient to dial it up or down. If they do shift and it becomes uncomfortable or conversely too low, then they'll, if they're, patients are usually pretty good with it. I trust they're not going to turn it up to make things worse. Let's have you lie on your back. Yes. The comment was keeping it for that long with the contraction can cause unneeded muscle soreness. All right, I push in, you push out. Go ahead. Push out. Very good. Super. All right, so we're going to get right into practicing. So I want you to do the 2-needle technique, clip it, get it running, do some soft tissue work, and then we'll go from there.